Good morning and welcome to the 22nd meeting of the Health and Sport Committee in 2019. We've received apologies this morning from Miles Briggs. Can I ask everyone in the room please to ensure that mobiles are off or on silent? While it is appropriate to use social media for mobile devices for social media, please do not take photographs or record proceedings. The first item on our agenda was heard in private. Our second item is the second of our evidence sessions for the second phase of our primary care inquiry, having heard from a number of witnesses last week. This week, may I welcome to the committee Jonathan Burton, the Chair of the Scottish Pharmacy Board of the Royal Pharmaceutical Society, Matt Barclay, Director of Operations with Community Pharmacy Scotland, David McCall, Chair of the Scottish Dental Practice Committee, British Dental Association, and David Quigley, Chair of the Optometry Scotland. Welcome to the session. You'll be aware that what we're looking at is a very broad-ranging consideration of what primary care should look like in the next generation and what changes are happening or should happen going forward. And part of that, if I may start with the question of integrated planning across primary care and across healthcare professions, can I ask each of the witnesses for your view how far you believe that integrated planning is taking place at a national level across all professions in healthcare, and what your own input to that might be. Who would like to start? It's a nice broad question to get us going. David Quigley.
Sorry, is your question as to what has been done or what could be done?
It's really looking what's happening at the moment and looking forward.
Okay, so I think colleagues we've had conversations before about what needs to be done. I think with regards to implementation, there's a common understanding that communication, integrated technology, electronic patient records, the ability actually to find out quickly what's required of us with regards to a patient's needs. I think these are things where the potential for us to work together is enormous. Clearly, the infrastructure is another question, but I think the willingness and opportunity is there. And I think also public awareness raising is a massive opportunity as well. I think everybody knows in various portions as to what's required with regards to sharing information, whether it's whether it's paper leaflets, whether it's social media, whether it's the press. But I think the opportunity to share the information that's required to allow people to make the right decisions as to where to go and when. It's not necessarily where to go, it's where not to go. It's to keep people from travelling inadvertently or to making appointments that just aren't necessary. So I think the more we can do to raise awareness, a common theme would be another big opportunity.
And do you feel that there is planning for that purpose going on at the moment? Is that your experience of work with health?
No.
Okay, thank you very much. Who else would like to? David McCall.
I think on the back of what David said there, we feel that IT integration is crucial to everything that happens in health. And what we have at the minute is we have clunky IT systems that don't talk to each other. Even within secondary care, they've got systems that don't talk to each other and they can't measure exactly what they're doing. We can't interface with secondary care very well. We have a very, very clunky referral system called Sky Gateway, which was a bolt-on service to the dental stuff that we have. It takes about 10 or 15 minutes to fill in any field. There's nothing that pre-populates. And as David says, we need access to electronic care summaries because we spend an inordinate amount of time with patients going through medical histories and getting updated medical histories. And I think if we had that in some type of electronic form, it would really help practice.
Okay.
I think I would echo much of what my colleagues have said already, but I think a lot has went on in terms of, certainly we had the National Clinical Strategy, we've had the hours review that was led by Sir Lewis Ritchie, we've had transformation monies. How effective that's all been in changing practice to date is questionable. I would certainly echo my colleagues with regards to information sharing around that. That's something that needs to improve for practice day to day, certainly from a community pharmacy context. and it would be really good to kind of get that joined up. I think there is things happening in the background in terms of that with regards to you know, obviously the conclusion of the GMS contract, and that's moving on in terms of information sharing arrangements, but it's certainly far from you know, a reality in practice as well. So I think the willingness is there, never more so actually than all the you know, the bodies that you see before you today are part of the Primary Care Clinical Professions Group. So we do meet as a group on a regular basis, and that was largely in the back of so much going on and a realisation that actually for all professions in primary care there was a need to look at areas of commonality and actually work as a group of professions to kind of work towards our common goals. So there is a willingness there from the profession side, and I think that just needs to be matched on the other side.
Okay. Jonathan Burton?
Yeah, I think it's fair to say that when you're talking about integration of healthcare, it's very difficult to integrate services when the professionals within those services can't easily communicate with one another. And we see this in pharmacy and community pharmacy practice, and it's echoed across some of the other contractor professions that sit outside the sort of the GP surgery model, that it's difficult for us to get access to patient records. There are changes starting to occur in some areas in Scotland, but still access to basic electronic care summaries is not part of commonplace practice in community pharmacy. But also, from a pharmacy perspective, the range of services and the complexity of the care that we offer is forever increasing. And what we're really also lacking is not just the ability to see records, but the ability to populate those records with a record of the care that we're providing. So that really does limit integration. And every minute that you spend struggling with communication with your colleagues is a minute that takes you away from the patient.
Brief supplementaries from Sandra White and Brian Hood.
Thank you very much, Convener, and good morning. David quickly mentioned the fact about awareness. Do you think a government campaign in regards to making the public aware of what they can actually access would be a good idea, whether it's government funded or NHS funded, something like the Seamy campaign?
Yeah, I think whether it's marketing or PR, it's awareness raising, and I think it just needs to be consistent. There are quite a number of platforms available to all of us with regards to information, whether it's online, whether it's through smart devices, or whether it's paper, it's in practices and surgeries.
I mean, a sort of a TV campaign.
Well, that's what I'm saying. So that would
for the public.
Yeah, I think public information campaigns of some description. Yeah, definitely. But it would have to be across a variety of disciplines, I would have thought. I think TV alone would do it.
Okay. Brian Hood.
Thank you. If I could, I was going to raise this later on around the IT infrastructure, but David McCall and Jonathan Burton have thankfully raised this really early. 100% agree that if that we require an IT system that actually all clinicians can actually access and input into and centrally. And currently we don't have that. So, but I think the fundamental question that has to be answered first is who owns patient data, or who should own patient data? Because we have lots of issues around about that, and there's a lot of different thought processes around that. But I have my own thoughts. But I wonder, from a clinical perspective, who do you think should own patient data?
David McCall.
If I can come into that, Brian, I mean the patient data and something like the electronic care summary. You don't need access to all of the patient records. There's only a certain amount of the record that you need access to for any one of the contractors here. The most important thing for us would probably be current medical history and current medication and any interactions you would have from that. We don't need access to the whole patient record.
So, again, layered access into an IT system and patient data, is something I would advocate completely, depending on what clinician, whether it's a GP, whether it's a pharmacist, whatever. What I'm asking you is specifically is who should own the patient data.
I suppose that's it's a legal question, really, isn't it?
I don't know.
You probably need a team of lawyers to delve through GDPR to find out who actually owns the patient data. I suppose at the end of the day, the patient has a right to have access to that patient data. So does the patient own it? Does the contractor own it? Because remember, the contractor is funding all of their own clinical software. It's not in the NHS and it's not government that's supplying it for them. Maybe that would be different if it was held centrally and probably cloud-based. My view for the way forward would be to not have this choice, and Matt and I were talking about this earlier on, the contractors have a choice of the clinical systems that they operate. Now, we would probably rather have one system that was upgraded and maintained throughout the whole of the NHS, because I think that would make NHS delivery a lot more easy. I suppose in terms of if it's held in a cloud, who owns that data? Does the NHS and ultimately the government own that data? Does the patient own that data?
No. The issue.
Well, let's not have a dialogue. Let's have a wider conversation. Matt Bartley and then David Quigley.
Yeah, I think for me, I think we're probably on part of a journey with regards to that, Brian, in terms of probably giving access wider within the professional networks is probably the right first step. But I think ultimately, if we want an informed and to empower patients, I think ultimately it should be them that own the data and authorise who sees the data for the right professional at the right time. So I think that's the end point for me. Yep. I do appreciate all the GDPR information governance, etc., that goes around that.
We agree.
Good.
David Quigley.
Yeah, I concur. It's the patient should own the data. I think GDPR determines how contractors are able to use the data thereafter.
Okay, excellent.
Yeah, I think what we need to be aiming for is a central digitised record that the patient has ownership of. And I think any of the professions that are arguing for increased access to records, increased ability to write into records, we need to be mindful that we need to take patients with us on that journey, and consent is absolutely essential. We should be using the appropriate information in the appropriate way.
Which brings me back to the answers to my first question and the sense I think I had from all of you that there are barriers to integration. Integration is not yet happening, and clearly we've followed a couple of lines of inquiry around that. Who, briefly, in your view, is responsible for delivering change and delivering that level of integration? Who should take the lead? Matt Bartley.
I think that has to be government that takes the lead on that. I mean, certainly the first paper that we drafted as a primary care clinical professions group was around digital enabled health technology, and one of the facets to that was around health information sharing. So all the professions agreed that a Once for Scotland approach is the right approach to take. And if you have, we've got 14 health boards, 31 health and social care partnerships. If you have a fragmentation of that across Scotland, then that could probably cause some of the issues in terms of integration. So that would certainly be what our view, my view is.
Yeah, David Quigley.
On a positive note, a very positive note, I think this collaboration is really important, and I think it's what you do with initiatives. So I think initiatives can come from all parties. Obviously, government has to take its place in supporting that. So over the last couple of years, with optometry, through a highly collaborative process, we managed to land electronic submissions for payments. And I know some of our colleagues have achieved that already. But for us, it was a very collaborative and cooperative experience, and it benefited everybody because it saved time, saved money, contractors get paid more quickly, and there was less wastage in the system. So I think we've got the potential again to do a lot together. The initiative, I don't think it matters where it comes from, it's actually who makes it land at the end of the day that counts.
Okay. David McCall.
I would agree with Matt. I think it has to be government-led. I think if you leave it down to individual boards, they will all do slightly different things in a slightly different way, and we will end up with systems not being able to communicate with each other again.
Okay. Thank you very much. Emma Harper.
Thank you, Convener. Good morning, panel. So if our IT systems and our communication with each other is all working fabulously, now we are ready to collaborate, as David Quigley mentions, and I'm looking at the wider role of the other, like dentistry, optometry, pharmacy, in collaboration for healthcare. So in some of the submissions, it says that community pharmacy could have an increased role in providing health advice, And Community Pharmacy Scotland said, we would like to see community pharmacies as a location that patients are referred to when they have a medical concern, which does not require a GP appointment. And we've had other submissions. Optometry is the first port of call for all eye-related problems, including emergency eye examinations. So I'm interested to hear about any discussions that might have taken place on the enhanced role for community pharmacy, and do you feel that pharmacists are best placed to undertake anticipatory care and preventative work?
Matt Bartley.
Yeah. Thanks, Chair. Yeah, I think some discussions are taking place, and certainly next year in April 2020 we have an evolution of our contract to open up and extend what is known as, I suppose, the minor ailment service, but it'll encapsulate a lot more, you know, some services around UTI and impetigo, for example, which have traditionally been done by GPs. So that type of thing is happening. I think going back to maybe Sandra's point around public awareness, we would look for, I suppose, a public awareness campaign to go hand in hand with that, to signpost people to the community pharmacy. But I suppose, aside from that, taking David Quigley's point earlier around collaboration between professions, there's nothing to stop you know, collaboration going on informally as well. Certainly organisations, Optometry Scotland and Community Pharmacy Scotland, have worked in the past to create, you know, referral pathways between community pharmacists and optometrists. And I know certainly, and I'm sure Jonathan will echo this, that very much local practice can see that embedded in an informal way as well. So a patient will come into a pharmacy with an eye complaint, you've not quite got the tools to deal with it in terms of community pharmacy, so we would refer them on to our optometry colleagues. That type of, I suppose, referral and you know, realising when you have to refer on to other things does happen on a day-to-day basis. And just, I suppose, we're looking for community pharmacy to be, I suppose, in terms of a generalist nature, that first protocol for kind of common clinical conditions as well, so we can take that pressure off other areas of the health service.
Yeah, I mean, if I can ask
Jonathan Burton, yeah.
Matt, I'm a practicing community pharmacist, and you know, over the past 15 years, I think it's fair to say that the pharmacy contract and the range and the depth of the services that we offer has been a continual evolution. But if you look at the complexity of what we do and the breadth of the service offering, I think we're at a point where, you know, we need to look at the resource that needs to go behind that. You know, the training and the continual professional development and the support that's needed to maintain that sort of first port of call access service. I very much consider myself the first port of call, but again, the lack of infrastructure and integration makes that challenging in a time where we've got an increasing number of patients coming to see us. So the evolution's been very positive, but we do need to take a serious look at the resources. I'm a massive fan of referring to optometry, but it is a rather clunky process. And I note that in the optometry submission, and it's not my place to comment on optometry remuneration, but I was very pleased to see the supplementary eye examinations mentioned there, and the fact that probably more support is needed to make those appointments more available. And I would very much second that, because, you know, we're the first port of call. You know, we're the guys that the people walk in and see. We need to be easily able to refer among one another, and that's both involving GPs and between the professions that you see here today. But you know, with the increasing complexity and the increasing workload, does come a resource ask there as well.
Okay. I think it's relevant to both the other professions as well. So feel free, David, quickly.
Yeah, so. Most optometry practices on the high street, and when you're on the high street, you don't turn people away. So from a public perspective, again, huge potential there to continue to offer that opportunity, that ability is substantial. I think with regards to what's happened in optometry since 2006, when GOS was reintroduced across the board, we've had the opportunity to compare and contrast ourselves, for example, with England, where the volume of outpatient work has increased by 40%, whereas in Scotland it's increased by 8%. So we can demonstrate that we are keeping people out of secondary care and out of the hospitals. With regards to education, we've now got a very willing group of clinicians who are actually much better placed to use the skills that we're trained to deploy, whereas beforehand that wasn't the case. So and also with the introduction of independent prescribing and other enhanced training, then we're able to do more and more in acute eye care. And obviously, again, it just goes back to what we said about awareness raising. The more the public are aware of this, the more they'll come directly to us. And I think it was mentioned before about availability. Well, many practices are open 6, if not 7 days a week. Many are able to offer extended hours. So if we're able to work in an environment where we can facilitate that and provide for it, it's endless possibilities, I think.
Okay, thank you very much.
So,
David McCall, did you perhaps want to add something?
I think certainly within the industry, we're one of the few professions who otherwise see well patients. So I think we've got an opportunity to pick up a lot of other disease processes, and diabetes does spring to mind in that kind of pre-diabetic condition that we could certainly pick up on. I think it is unusual. We see people every 6 months who are otherwise well.
Yeah, opportunities.
At that point, there was some research produced from Aberdeen University recently from Dr. Zangalida's the second paper, which again, with regards to routine examinations, the detection of high blood pressure had actually improved with regards to people taking routine examinations, just because that was being detected as a matter of course.
Yeah.
yep, we've actually had debates about how optometrists can be key to picking up type 2 diabetes and then referring on as well. So it's actually quite valuable. My sister's an ophthalmic nurse specialist, so I hear all about eyes and stuff like that. But she works in Carlisle, and there's definitely a difference in the care and treatment. In Scotland, it seems to be a lot more positive, actually. So if we were to have everybody then collaborate and work together, and, how do we fund all that? How would you suggest that we fund? Do we need more pharmacists? Do we need more optometrists? How would we fund all those training requirements?
Simply saying more money for everybody won't quite do the trick. So with that health warning, David Quigley.
Wasn't about to say that, but so in optometry, there's a new provision being created in Inverness at UHI. So we're looking to see more optometrists coming out of UHI. There's been a massive shortage in Highland and in Grampian for a very long time. So that will ease that. Because of the vagaries of supply and demand, that has shoved up the cost of providing optometrists in those areas. So increasing the supply into those areas will help address that. So that, at least from a practical point of view, will help with the cost of delivering optometry to a certain extent. With regards to funding, I think if you can evaluate the efficiencies, we have demonstrated that we can save £71 million, whether that's in cash or redeploying resources in secondary care. If there's any way of creating some kind of opportunity to monetize that and bring it back, then that would be an opportunity indeed. But it's got to be down to fees in our case have not been increased for 10 years. Rent rates haven't moved very much over that period of time, but the cost of people certainly has massively. So, and also in terms of capital, you mentioned about the detection of diabetes and other diseases with ocular tomography now, which is, I mean, we get granted, and we're very grateful for that 10 years ago for fundus cameras. The next generation of tomographers do a much deeper dive into the retina. Detection of all manner of ailments, including diabetes, is much easier. And we've had some great discussions recently about generating a centralised AI database, so we can actually start to remotely diagnose and track the changes every time one of these is carried out. So again, needs a bit of investment and collaboration, but it's all there.
Okay. Matt Bartley.
Yeah, I think, as Jonathan was saying, the complexity certainly in community pharmacy is increasing in terms of the amount of people that are coming in and seeing us as that kind of first protocol. So I would echo his call for resource to go into the training to kind of match that. And we are working in partnership with the Pharmacy and Medicines Division to to develop the contract in that direction. So I mentioned the kind of new pharmacy first stroke extended minor ailment service next year. We're also looking at a coordinated independent prescribing strategy as well, because we ultimately see that as being, you know, an end point for community pharmacists to have independent prescribing status and dealing with patients, you know, that come through, you know, the door with that skill set in mind as well. So I think, yeah, it's easy to say more money, but we are certainly working within our financial envelope to shift money from certain areas to support, you know, what ourselves and the government see as, or the, you know, the department see as strategic areas that we need to. And I think we're not looking for huge amounts of money to supplement that, but there is bits, as Jonathan says, that actually we do need more resource to support the direction of travel, certainly for community pharmacy.
Okay.
Just a final question. It might be that David Quigley answers this one. Is there any resistance towards any like using optometry as the primary spot where people go for their emergency eye or their treatment or anything?
I think that there shouldn't be. I think in the past there might have been some resistance from ophthalmology for inappropriate referrals. You know, if things become too sophisticated, if your detection methodology improves too much, then you begin to over-refer, but it's actually proven not to be the case. The better our diagnostic methods are, and the better equipment is, the more accurately we can refer. And in Grampian we showed that with, again, the workforce there had a higher level of training within the Grampian Eye Health Network, and they're able to demonstrate there. And that's been a very collaborative exercise, repeated to an extent in Lanarkshire and in Ayrshire, but hugely collaborative with ophthalmology and optometry. So I think a lot of those barriers were broken down. If you could emulate that, and again, many more people retained in the community, and far fewer numbers being referred, and the accuracy of referral increased enormously, up over 80%. So that's an exemplar that we'd really love to emulate throughout the whole country.
Okay. Just wondering, a wee final question. How long does it take to break the barriers down? Is it 6 months? Is it just a process that when you reflect back, you think, okay, that's taken 5 years for people to realise that they can go to pharmacy as a first point of contact, or they can go to optometry for their eye health exams?
Jonathan Burton?
Come back on that one, and wanted to just skip back a couple of questions as well, if that was allowable. Yeah, I think it's an evolutionary process. If I look back 10, 15 years, there were occasionally eyebrows raised when pharmacists referred to our clientele as patients rather than customers, and thankfully those days, I would think, are long gone now. And just going back to the previous question regarding, you know, the acceptability of our service to others in the medical professions, perhaps. I mean, certainly I would say the vast majority of GPs are very supportive of our frontline role in community pharmacy, and are very supportive of having GP practice pharmacist colleagues working alongside them shoulder to shoulder within their buildings. You know, we all have a role to play, and it's not just about easing the workload or the pressures on any one profession. Quite often it's quoted that, you know, our work saves GP time. It's not about saving GP time. It's making sure that patients have good access to the appropriate level of care, so that we can all do what we're best at. In our submission, we mentioned transformational change, and just looking at the sort of pharmacy picture, you know, what we would like to see is a continuation of this evolution in community pharmacy practice, so that our remuneration, our support, our training very much supports pharmacists offering patients a package of care, not just the package of their medicine. So we would like to see that continue. And, you know, as we've said many times before today, you know, the complexity of what we do is ever increasing. But if you look at what the public wants, if you look back at the evaluation of the minor ailments service, that was an independent evaluation done by the 2 schools of pharmacy. What patients really value is accessibility. They value being able to speak to somebody who they are familiar with, and they also value the fact that they don't need an appointment. And it does take resource to offer those sorts of services in the community, but I feel that is the right way to offer care. We're very, very fortunate that we have such amazing networks of pharmacies, of optometry practices, of dental practices across the country, and we really need to utilise the fact that we are close to where our patients are.
Thank you very much.
Thanks.
Thank you very much. I had a brief question from Sandra and then Brian
It's
Whittle.
answered. Thank you very much.
Okay,
Jim.
Brian Whittle.
Thank you. Just a very, very quick one, actually. I think if we're going to maximise the skill set of a pharmacist, I don't know if you agree that what we want is pharmacists to have more time front of house in front of patients. And anecdotally, I've heard from quite a number of pharmacists that one of the things they could do is train some staff to look at helping to dispense medicines. So the pharmacist doesn't have to do that role constantly as well. But I heard that as soon as they do that, they get pinched by secondary care. Do we have when we're always talking about the number of frontline staff in terms of clinicians we need, are we failing to look behind that, the support network?
Crisis in pharmacy, is that what you're asking?
No, I'm not asking. I never mentioned the word crisis. I never would use that word.
Jonathan.
Okay, so yeah, we have a finite number of pharmacists working in Scotland. There are quite a few of us. There are over 4,000. We're the third largest profession, but I think it's fair to say that our skills really are in demand. We all know that medicines can be wonderful things and can do fantastic things for people's health, but medicines can be risky and medicines can sometimes cause harm. And because of that, our profession's knowledge and skills is very sought after. And that has led to some fundamental changes in the GMS contract, and many of our pharmacist colleagues are now actively working side by side with GPs and nurses in practices, and that's a very positive thing. But like I said before, we're a finite workforce. We're in hospitals, we're in community pharmacies. There's only so much of our time to go around, and yes, we do need, I would argue, more highly trained support staff. We have a very hard-working workforce who already do a lot of the dispensing and technical activities for us. But I think it's fair to say that transformation has probably been more rapid in hospital practice than it has been in community practice, and there are many underlying reasons for that. But we need to make sure that we're able to put our pharmacists where they're needed, which is right in front of the patient. And at the moment, we have some issues with that. Our workforce is becoming increasingly stretched, and the Pharmaceutical Society, we don't believe that's in anybody's interest, let least alone patients. It is a positive thing that we are able to work in GP practices, but if our services are taken away from our hospital wards, our community pharmacy consultation rooms, that will have a negative feedback effect on those very GP practices. Again, it's making sure that patients get accessible, safe healthcare and are not always gravitating towards the GP practice for anything and everything. So we need to look at our workforce planning. We have a lot of workforce surveys which are throwing off a lot of interesting information, but so far we do not have a coherent plan which takes account of the fact that patients and our fellow professionals need us in a lot of different settings. Wherever there's medicines, there needs to be pharmacist input, whether that's administrative and technical, or whether it's right there with the patient and the doctor and the nurse. And that's becoming increasingly difficult.
Okay, thank you very much. Some food for thought there. I think I have a brief supplementary from David Stewart and then George Haddon.
Yeah, could I let George come in first? I come back to
Okay,
workforce planning.
Thank you very much. George Haddon, please.
All right, thank you, convener. Good morning. During the summer we went on a away day. We met with some members of the public, and one of the tasks we had was to redesign the health service how you would want it. And every one of us literally moved away from the idea, exactly what you were saying, Jonathan, of the GP and more to a kind of health hub type ideal. So basically with that in mind, each of your professions, how do you see, if you had that kind of blank canvas to work on, and where do you see your prevention and your profession involved in that with regards to prevention and ensuring that we have health promotion agenda as well?
Who would like to start? David, quickly.
So Hubs. I quite like the notion of that, but if it involves being out of the, or on the edge of the community somewhere, that involves travel, etc., etc. I think if you can create things that are within the existing provision. So, for example, we're all already located where we're located. I think if the public are aware that there are more services available.
Sorry, David, the point I'm trying to really get at is we literally, if someone gets ill, they go to the GP regardless. You know, and that has a knock-on effect in surgeries.
Okay.
So what we were more or less, the hubs were part of it, but it wasn't the main issue. The main issue was the fact that, you know, people's idea of, they already have that, the public has that idea of accessing other professionals and professions, and just in how do we make that work?
Okay.
You know, if we've got that blank canvas.
Okay. Well, I think if you had the blank canvas, then with regards to the individual disciplines, whether it's eyes, so whether optometrists become GPs of the eyes, for example, I think that's something that we've spoken about before. I don't know if that's nearer to answering your question, but I think if you're able to start fundamentally of getting people to go where it is they need to go with their particular symptom or with whichever part of their anatomy it involves, that's certainly going to be a start, because it's about reducing unnecessary travel, reducing unnecessary visits. The thing about anyone who goes for any form of medical care, there's already going to be a degree of trepidation about going. If you add into that, are they in the right place, the right department? Are they going to see the right person? How long are they going to have to wait? As was already mentioned, if you're in a familiar environment, one where you're comfortable and you get to know the people that are within that environment, it's going to make it an awful lot easier to address whatever concerns you've got and have them dealt with there rather than being referred anywhere else.
Matt Barkley.
Yeah, I think, I mean, it was interesting to read even phase one of some of those meetings, George, that certainly you had with the public, and it was heartening to see that actually they didn't regard the status quo as the option, so that they wanted this evolution to continue, and I certainly think that is quite heartening. And they also mentioned, I suppose, the professionals that they most want to see. So I think mental health professionals, nurses, etc., were top, physiotherapists, and then pharmacists were next. So that was kind of heartening to see that, and actually a large majority as well wanted their information to be shared. So that was fine. I think it is about, although a community pharmacy operates within a building, and you know, certainly our GP colleagues operate from a building, and the many health professionals that are in that setting as well, and as do our other colleagues. It is more of creating a kind of virtual hub where actually things, you know, do happen, and things that patients are transferred seamlessly throughout that. You know, whether that be through the public awareness, making sure that they're aware of which professional to see at the right time for the right reason. Or whether that's, you know, within the profession, so that we're then able to refer on, and as well linking, I suppose, to secondary care expertise as and when it's required as well, because I think that's probably one thing that, you know, as a generalist myself, I can only take it so far, but actually being able to refer on, as we talked about, to experts as well. So I don't know if that answers your question or not, but I kind of gets around. That's what I'd like to see, I suppose, in the future, is obviously still being at the heart of communities, patients coming to see us as and when required, hopefully with an upskilled workforce at front and back, so that the technical stuff's done, and the pharmacists seeing patients up front, but actually that we share that with you know, the wider primary care workforce as well.
Okay. David McCall.
George, it's a very interesting concept. If you had a blank canvas, what would you do again? Having been in the same practice now for 32 years, I think prevention would be the key. Currently, we're not really that well funded for prevention. It's all loaded onto treatment. Skill mixed with prevention is key to this. It doesn't necessarily take a dentist to deliver that. We have enhanced duty dental nurses, and we have therapists that could do it with the dentist at the lead. That's where I would start with it. I would start with investing in prevention now.
Sure.
Yes, the other thing I was going to ask, and it kind of follows on, obviously, I always use the example of my wife, Stacey, has multiple sclerosis, long-term condition. She keeps telling me I should stop talking about that. She's got another 2 chronic conditions as well. She likes to brag about these things. But she's quite proactive, and she manages herself through the system. It's taken a while to get her to that place, but She manages herself, she'll talk to her MS nurse, very rarely goes to the GP, because the GP literally, she probably knows more about MS than he does. You know, so the difference that we have is, how do we get that into that position in order for your profession to be a major part and helpful to the person that's the patient that's coming towards to yourself. They need to be empowered and they need to be able to do that. So how do you see your professions actually empowering people to be able to, you know, just get through the NHS that way as well? Because that's probably an easier way for us to actually get people through the system than the whole idea of re-education and redeveloping the system.
Jonathan Burton.
Yeah, I absolutely agree with that. I think anybody working on the front line will tell you that you're part health professional, you're part navigator, you're part advisor, and very much that's something we feel in community pharmacy that we could significantly build on if we were only better linked into the system. And it all comes back to the arguments about central patient records, about electronic communication and referral between different agencies, and just making that as slick as possible. Because if you can navigate a patient through the service and explain to them why they need to see their dentist or why they actually should see their optometrist about this particular eye problem that they've gravitated towards us with, and you can smoothly facilitate moving that patient onto the right service, that's a powerful message in itself. You know, I spend a lot of my time working with young people. I work in a pharmacy that serves a predominantly student population, and it's a joy to be able to teach people how to use the NHS properly at that early stage in their adult life, and people really do respond to that. So it's partly about first point of contact, helping people with their symptoms, picking up on more serious things that need referral, but it's partly educating people about how to use the service and how to self-care appropriately, how to look after themselves. In my pharmacy, in my consultation room, I'm an independent prescriber. I have 2 pads on my desk. I have a prescription pad, and then I have a pad of leaflets, which are called target self-care leaflets, which explain to people common symptoms, how long they should last, and when it really is necessary to see a doctor, and why it's not appropriate to take antibiotics. I tear more of those off the pad than I do off the prescription pad, and that's where we need to be.
David, quickly.
I think that was very well put. I couldn't agree more. And to David's point as well on prevention, I think that's one thing that we certainly can take on board as primary care providers to enhance people's knowledge and actually put a little bit more emphasis on their looking after their own health. The only thing I would have mentioned as well, at the other end of the spectrum, we will have an increasing number of people who are probably unable to visit premises. Therefore, anything that they can access safely online is going to become increasingly important. But what sits in between that as well will be what we do with the provision of domiciliary services, because there are about, I think only about 25% of the people who are eligible for home visits in optometry actually receive that service. So how many people do we have there who are developing other medical issues as a result of not being seen when they could be seen? So I think it goes back down to communication, it goes back down to awareness raising, but there are an increasing number of people who can't come to us, to any of us, that are going to require more visits at home.
Okay. Thank you very much.
Can I just add one final bit? Just basically, so what we're saying after all that is, in order to kind of make this work, or for it to be, information sharing is the #1 priority for all of you guys, to make sure you've got the access you need at the time you need it for the patient. It's a pretty basic question, but I want it on the record.
I see nodding heads.
Nodding head doesn't help with the official record.
I think concur all round. Thank you very much. David Stewart.
Good morning, panel. Could I return to workforce planning? I think Jonathan Burton touched on that in answer to my colleague Brian Whittle. I mean, how effective is workforce planning for your own individual occupations?
David, quickly.
It's very, very difficult. If you're just talking about professional colleagues who are on various registers, we know whether or not they're registered. We know whether or not they're listed with various health boards, but what we don't know is whether or not they're full-time or part-time, so we don't actually know how many hours have been delivered. What will help us enormous will be central listing, which is something that we've been aspiring to for some considerable time, but centralised listing will give us a better idea of who's where and when, and that in turn will give us a better opportunity to make for the provision wherever it's required. But it's not an exact science, and as everyone will be aware, in many of the vocational professions, the demographics of those professions have changed significantly in the last 10 to 15 years. So it's adding in these other factors that makes it all the more complicated.
Okay, thank you. Dave McCall?
I think, and as David says, it's certainly not an exact science, and it's never been well worked out what workforce planning should be. With the demographics of people, you don't know who's full-time, who's part-time, who's maybe left the profession for a little while, who's back again. Certainly what we are finding now is that a lot of younger practitioners are coming out, working in a stressed environment, and they're leaving dentistry. I think what we need to find out is why these younger people are leaving dentistry.
Yeah.
You know, you're spending £250,000 to train these professionals for them to leave after 2, 3, 4 years. You know, not just leaving dentistry, but possibly going to Australia and further afield. We've got to look at why they're leaving.
You?
I think we're working in a stressful environment. I think certainly our regulator, General Dental Council, has not helped. I think everyone probably knows that. Yeah, we're trying to address that. We're trying to get local resolution within Scotland at the minute without things having to be patriated down to the GDC at London.
Yeah.
Get them back here again. Patient expectation is high. I think there are certain things that aren't deliverable under the current NHS system. It's multifactorial.
I mean, the two Davids, I think, have made very relevant, but frankly quite scary points. I mean, at its most basic, we don't know how many full-time or part-time members of staff there are. It must be extremely difficult to plan for the future when you don't have this very basic data in order to look at projections for the future.
It's very difficult, David. What we're hearing is that practitioners, when they come out and they start working in the first 2 or 3 years of work, they don't want to work full week. They don't want to work any late nights. They don't want to work any weekends. They want 8 weeks holiday a year. And this is just, I don't know if it's just a reflection on people's expectations now when they start into a career. I don't know what the rest of the panel think about this.
It's déjà vu all over again, as they say. I think the challenge now is that we all, you know, everyone's aspirations seem to be globalised and based on sometimes anecdotal information from wherever it is they get their information from. So I know in medicine, met with one of the deans of one of the medical faculties, I think, said that after FY2, a huge proportion of doctors just vanish for a while because they've had 7 years of intense work and study, and they just have to take a time out, which is understandable. In our own discipline, what I've noticed increasingly recently, to David's point, is that numbers of newly qualified persons are actually leaving, and not necessarily permanently, but they're leaving to take time out, or some of them, people who are literally just qualified, are looking for part-time work. So I think part of the challenge there, I think educationally we need to look at who it is that we're actually recruiting onto these programmes and managing their expectations from a very early stage. I can't speak for dentistry and pharmacy, but certainly at optometry there's a certain portion of the cohort who aren't necessarily suited to general practice and to dealing face-to-face with the public. That's an issue. Working aspirations are an issue, and the willingness to, if you have, my dad's a retired GP, if you had him in here, we'd be here all day talking about the hours that he would put in as a junior doctor, etc. And that kind of apprenticeship mentality just doesn't exist. People are going straight for gold, and if they don't get it, then they're looking for alternatives really quickly. So there's a number of factors that.
Martin.
Thank you.
Yeah, I think I recognise many of the challenges that my colleagues from dentistry and optometry have highlighted there. I think it is a challenge for pharmacy, but it's no different. We're not a controlled profession, so our numbers aren't controlled like medicine, teaching, nursing, etc. So It's difficult even from that perspective to plan to a degree. As Jonathan mentioned earlier, we have had a couple of rounds of workforce surveys, certainly in community pharmacy, to try and understand the numbers out there, not just of pharmacists, but of support staff as well. That has presented a few challenges as well, in terms of we've probably realised now in the department as well, need to realise that actually we need to probably do a bit more work behind that to understand the numbers a bit better, because it's not quite given us a clear picture. We have a movement of pharmacists and technicians to the new roles that have been created through the pharmacotherapy element of the priority area in the GP contract. That's about 600 pharmacists in 6 years that they're looking for, started 3 years ago. So there is a strain on the community pharmacy workforce. We probably need to understand that more. And like my colleagues, there's different expectations around portfolio working, for example, with pharmacists wanting to do different roles in different areas. And actually that could actually be a benefit, but it does prevent a challenge when you're looking to provide, I suppose, the continuity and quality of care in certain sectors as well. But there are opportunities. I do see this move, like Jonathan, to have GP pharmacists as advocates for the profession within GP practice, working with GPs and nurses, etc. there as a positive thing. So I think we can use that in a positive sense. But yeah, a number of challenges in workforce as well in pharmacy.
So would having your occupation as a controlled occupation help? Or what would the steps be to getting a more sophisticated workforce management for the future?
It's probably, I'm not sure if the universities would thank me for saying anything with regards to that, actually, David. I think they have a view that actually they quite like how it sits at the minute, to be honest. And I probably, it may help, because if obviously if we could control the numbers nationally and the funding was there to support that, then yeah, having a controlled intake to support the needs of the modern pharmacy workforce would seem to make sense. We are as well undergoing a review of the pharmacy undergraduate course at the minute, and that looks at everything from recruitment to and admissions, to a lot of the points that David Quigley was raising around is it the right people that we're getting into the profession, to funding, etc., and quality and governance. So we're doing those kind of reviews in the background, hand in hand with all other stakeholders there.
Can I ask Jonathan Burton as well? I think you have.
Yeah, I mean, I think in answer to the initial question, we have a lot of workforce information gathering going on at the moment. I think that's fair to say, but not as much planning. And obviously you need the information before you can plan. So in a way that's understandable. But, when you look at, the development of the GP contract and, the fantastic work that pharmacists are doing who are being, quite frankly, parachuted into practices that are really struggling and really, putting their full expertise into helping the patients of those practices still get a really good standard of care. It's our colleagues are doing some really, really great work, but it's a pressure environment. And the feedback that we get from the Royal Pharmaceutical Society, our members come from all sectors of the profession, and the feedback we get from our members who are working in GP practices is that the pharmacotherapy component of the GMS contract, has brought some really significant challenges for them in terms of whether their time is really being used in the best way possible in terms of patient-facing care, or whether it's being used in a more technical, administrative sense, to keep practices functioning smoothly. So we need to be mindful of that. It's all about making sure that people are doing the best job that they can with the skills and the knowledge that they have, and we're not quite achieving that yet. And we've spoken before about the negative impact that possibly the lack of planning around the sheer numbers of pharmacists and technicians that we need to provide great care in these practices, the impact that has on the rest of the service. And I know we're talking about primary care, but we're not, but we're talking about impact in local communities for small teams in community pharmacies, and we're also talking about the expertise that junior doctors and senior doctors and patients have access to in our hospital service as well when we get really poorly and we need to be in secondary care. So it affects the whole system. So we need to plan better for how we use pharmacists across the piece.
Thank you very much. David, quickly, briefly.
I do like to finish on a positive note on these things. On optometry, as I mentioned before, but UHI, which is University of Highlands Islands, they're going for that will increase the number of optometry graduates. We're hoping by about 25 to 35% initially, so that'll make a huge difference, especially the north and northeast. But also, it's going to be a community-based programme mirrored on the University of Melbourne programme. So that we believe that's going to be transformational with regards to the experience, because obviously the students are going to be experiencing community optometry from a very early stage, and I think that will help iron out some of the challenges that I mentioned earlier.
Yeah. Well, that takes me very nicely on my last question, which is the particular demands of working in remote and rural areas. And obviously, covering Highlands and Islands, I've got certain experience on that. Could I perhaps start with Mr McCall, because I know that dentists, I think there's a £9,000 allowance of a maximum to try and encourage dentists in remote and rural areas. Could you tell me a little bit more how effective that is and what demands and challenges you've picked up in the profession in the Dumfries and Galloways and Highlands and Islands, for example?
I think certainly, I think back on new graduates coming out, they all want to be in the central belt. No one really wants to move out with it. And you can understand some young people, they might all want to be in remote and rural areas. It's probably not going to suit everyone. And I think any enhancement you can give to try and recruit people to remote and rural areas is good. One of our worries would be the corporatisation of dentistry, with the corporate bodies buying up dental practices. And if you had a corporate body owning a dental practice in a remote and rural area and it wasn't delivering an income for that corporate body, they might just shut it down. And I think that's what's happened in Inverness, that the practice has shut in Inverness over the past 4 weeks. Because the chap who runs the practice, he doesn't work in it himself, I understand, but he couldn't get staff to work in it. It's how we attract people to work in remote and rural areas.
So is your point that a traditional model contractor where the professional is in and operates the business is more likely to remain rooted in the community? Is that?
So.
Okay.
I think so, because there's a very high turnover of dental staff within corporate body dental practices, and there is no real continuity of care. And for that continuity of care, I think that the standard model of a family dental practice is probably the best model.
Okay.
Other colleagues in relation to rural practice?
Yeah, I think in terms of what we're hearing from rural members is the workforce challenge as well, in terms of getting bodies to actually work in practices as well. But what I do also see just through correspondence amongst the professions is really some really good innovation happening in remote and rural, and quite often that kind of NHS Near Me, for example, in Highland is an excellent example of that. I led a pharmacist, like Claire Morrison, leading up that and really developing a type of remote and I suppose virtual consultation with patients in a very different way, and actually there's a lot of things that can be taken from that type of innovation that actually can be used elsewhere. But certainly in general what we're certainly hearing is workforce challenges are the main concern for some of our members in remote and rural areas.
Okay, thank you very much. Okay, we'll come back to Sandra in a moment. David, quickly.
Sorry, so UHI, as David said, when you've got students living in Glasgow for 4 years, for whatever reason they don't want to leave, so irrespective of where they come from, getting them back is a real challenge. So with UHI, that's going to the whole ethos of that will change things. It doesn't address everything necessarily, though, because there are some communities that are even harder to reach. So therefore, I think easing up the provision whereby you can offer domicile or mobile organisations who are already in that arena, maybe encourage them or make it easier for them to go and operate in some of the more remote communities, because if they've got the facility to be mobile in someone's home, then they could be mobile, in a church hall or a community hall, for example, to provide that service. I think the only issue in the past sometimes has been actually getting the regulatory bodies to agree to that premises as being fit for purpose, etc. But I do think that providing more encouragement for organisations to do it, but to the point as well, it's still down to getting the professionals in situ, and I think UHI for us will help address that.
Okay, thank you very much. I have Sandra White and then Alec.
Thank you very much, Convener. Before I go into my original question, which was the very first supplementary I asked about awareness raising and culture and education, just a small sup on the back of Dave Stewart's question in regards to local community, particularly pharmacies, but others as well. In my area in Glasgow, Kelvin, I get a lot of requests to open up community pharmacies, opticians, etc., mostly community pharmacies, and a number of them get refused. Now, I don't know why they get refused, but they do, and we have lots of students now in Glasgow who need more pharmacies, doctors, particularly in the universities. Why is that they get refused? Is there a blockage on how many community pharmacies or opticians, whatever, or dentists in an area? Who blocks that?
At Barclay.
Yeah, well, I can certainly talk for community pharmacy, Sandra, in that there's a control of entry system for pharmacies, so you can't open up a pharmacy anywhere, so you need to demonstrate whether a pharmacy is necessary or desirable within a given area. So there's a legal test that's applied as part of a pharmacy practices hearing, where you will have an applicant for a new pharmacy and you will have people who maybe don't want the new pharmacy to open, and it goes through that kind of legal process. So there's a system in place to control the numbers in pharmacy, because if you open it up to, I suppose, a free market, there is the idea that there might be an impact on service provision. We have, for example, members who probably can invest in Glasgow, for example, in their premises and in their staff, simply because they know in their own area they're not going to have a pharmacy that will just open up, be able to open up the street, for example. So they do put that resource back into their business as a result of having that, I suppose, comfort. But indeed, where there is that process that a new pharmacy can apply, and if the legal test is passed, then pharmacy contracts are granted.
I don't want to get the legal aspect of it, but certainly with a large influx of overseas students in my Kelvin constituency, it seems to be the corporate companies who are the ones who are blocking individual pharmacies from opening. I just wanted to get that on the record. I don't know about the other professions or not, if that happens to them.
David, quickly.
There are no limitations at all, save for the practicalities of running a viable business operation. There are none.
And the same for dentistry, there's no restriction on the amount of dental practice.
Okay, thank you very much.
It's just pharmacies, okay, I'll remember that one. I wanted to go back to the first supplementary that I'd asked about awareness raising, and I think we're all agreed it is absolutely necessary. But to raise awareness, I think we need to change the culture, and you mentioned education as well. And it's not just changing the culture for the general public, it's also about professionals being aware of what's available as well. Basically, I really was impressed, Jonathan, when you mentioned the fact that you've got the 2 prescriptions pads, and I just wondered, and David had mentioned the fact it might be quite complicated to have a TV advert, etc., etc. So how would we create this awareness in that respect of perhaps TV adverts or the prescription? I mean, I can actually see it just now with the 2 prescription pads. I think that would be a great advert in that respect. Will it be complicated? Will it be difficult? And do you think the professionals, i.e. the health professionals, social care professionals, are they aware enough about what actually is happening on the ground? Do they need to be educated and made aware of what is actually there, and not just people having to turn up to their GPs and being told? Because in that respect.
Yep. David, quickly.
I think it's clear here we've got an awful lot of cross-party agreements. So I think culturally we're already in the same space. Whether that extends to GPs, I think it does in many cases, and then into secondary provision. I think it's just having that common purpose. Once we've agreed that purpose, it's much easier to promote it and market it. I think before you promote anything, you'd want to have a bit of a sense check as to who's on the same page. And once everybody is, it makes it much easier to promote. It's almost like internal PR first and then market it afterwards.
David McCall.
I think it's an interesting point, Sandra. I probably feel that all the contractors sitting in this side of the table here have been largely marginalised over the years in terms of secondary care. So when you say, do we know what's really going on the ground? Well, the answer probably is no. We don't really know what happens within a GP practice. We don't know how their processes interact with secondary care. We don't really know what happens within secondary care. And I think we probably need some type of communication there to find out what is going on the ground.
Thank you very much. Jonathan Burton, did you want to add?
Yeah, I mean, I think at the end, a lot of this comes down to communication and how we're all linked up. Like I said, we can help patients on their journeys, but those journeys need to be smooth, and we need that reassurance that when we refer somebody on, there's a good process there. We mentioned in our submission about the possibility of interacting more with school-age children around healthcare and self-care, and helping people from a very early age to just have a little bit more knowledge about the system and the expectations there. And I think we need to look at our undergrad training and also opportunities postgraduate for linking up with the other professions. It was only during my clinical skills training that I did as part of my common conditions clinic offering that I really started to appreciate the impact that community optometry has with eye care. So that's substantially increased the number of referrals and hopefully the quality of those referrals. And I'm sure there would be opportunities earlier in people's careers to get those messages across as well.
Okay, thank you.
Just a very small. Sorry, it was very small. I know that in dentistry they do go out to schools and it's educated through that. I should declare an interest. My daughter works in dentistry, but I know they go out to schools. So you think something like that would be helpful for all of the professions?
I think it's about self-care and looking after yourself and knowing a little bit about the NHS, not necessarily focused on one particular profession, but just a sort of generalised good start.
Thank you, Chair.
Thank you very much. Got David Torrance on data, and then I think Alec Cole-Hamilton will come back in on some of the workforce issues. David.
Thank you, Convener. I think all my questions have been answered on that, but I'd like to follow up just a wee bit with what Sandra was saying there. Educating the public about what services are out there. Community pharmacies are often an integral part of small local communities. Would you not be better doing it yourself? I know everybody says the government should advertise what services are out there, but would you not be better doing it yourself, or can you? And what role does social media play in this? Because I know many small towns, villages have their own Facebook pages, and they're very quick at getting it out there, what good things are happening in the towns.
Matt Bartley.
Yeah, thanks, Dave. Yeah, I think Jonathan mentioned it earlier, actually, in terms of if the best advocate, and I suppose the best advocate for any profession is how you actually deal with the patient that's in front of you, and then, either help them at the time if you can, or signpost them on. So I think there certainly is an element of, we can do it ourselves and we can maybe shout about it a bit more in our local communities. I would agree with that. And I think some of our members do that, to be fair. But I do think there needs to be an overarching message, I suppose, from the centre in terms of, we've got the policy intent, we've got the various strategy documents, that have led, and we certainly have one in pharmacy as well. But we do need, if there's that fundamental change in the way that primary care has been developed, then it would support, I think, the individual professions, and certainly in pharmacy it would support, that going to the right person at the right time, the pharmacy first message, for example. That could be done through pharmacies. Social media, I think, does have a large role to play in that. I think it's certainly a positive message to put out there about, what all the professions can do. But yeah, I think it's probably a mixture in answer to your question, David.
Thank you.
David, quickly.
Back to George's point about starting all over again, or starting with a blank sheet of paper, I think, and going back to Jonathan's point on prevention, and David's too, prevention it's not necessarily ruled out the moment someone has to attend a professional for any kind of medical condition or a pharmacy for medicaments. It's an ongoing process. You can always, at some point, make a decision actually to take control of your own well-being and take the steps, or to either start or stop doing various things. So if I was doing it all over again, I think I would have the preventative agenda as a thread running through everything. And I think once you have a common thread of that nature, and it is probably more PR than marketing, I think Facebook, etc., fantastic. You need to be very careful what you put out in social media, we know that. But I think if you have that thread going through as a message to the public, then I think then all of us are in a position to support that. You could include, you know, if you had a strap line or something, you could include that in every piece of literature you have, every prescription pad you have, every leaflet you've got, every poster you have, and every advert that you put in TV or radio. So I think it's just agreeing. If you know, we're pretty much there. I think it's if you manage to pick up a common strap line or a thread that can carry through everything would be helpful.
Okay, thank you very much. Alec Culham.
Thank you, Convener. It's not actually about workforce I wish to ask. It's about a couple of areas we've covered to a certain degree already. The first is about prescribing, and so particularly for our pharmacy friends. This committee is very aware that a big component of health inflation in this country comes from GP prescribing. That's not the fault of GPs, that's a symptom of our times and the ageing population and the multiple comorbidities people present with. But can I ask about the culture that exists? When somebody presents at a pharmacy with a long script of medications that they're on, and they tell you why, or they tell pharmacists why they've been prescribed this. If the pharmacist says, actually, there's a simpler way of dealing with this that doesn't involve all these medications, or actually, that's not going to do you any good at all for that condition. If you disagree with the prescription of the GP, what happens then?
Certainly, I mean, I'll like Jonathan to speak as well to this, but certainly for me, if you know, I have a patient coming into the pharmacy that I'm going to be looking in on Saturday, then, and they say exactly that to me, Alec, I would probably, if we're really living I suppose the values of the NHS, and I suppose putting patient at the centre, you would listen to that, and you would obviously understand what the patient's understanding is. You would work with that patient to see what the better potential solution is, and you would then have a conversation with the patient and the GP to try and get that prescription kind of amended. I think it is an interesting question, though, because we do have an element of our contract which was, I'll just call it the chronic medication service at the minute, but it's actually got a new name, but I think most of the committee might be more familiar with that, where we should be supporting long-term conditions, and we do support people with long-term conditions around the prescriptions that they get to reduce waste, to reduce, you know, make sure that they're getting the best from their medication with you know, the lowest number of side effects. And as we know, the more medications people are on, the more at risk they can be sometimes of side effects. And I think we have to work within that and contractualise that more within a community pharmacy context. And that's certainly the job of, you know, my organisation, to work with in partnership and build on what we've started and try and you know, so in answer to the question, if a patient comes in, you deal with that as you should anything, and you know, the patient's needs are paramount, but actually we need to have that recognised in a contractual sense to move that on.
But you need to make a direct referral back to the GP if you disagree with the
Yes. Ultimately, the minute, I mean, Jonathan and actually myself, I'm an independent prescriber. I don't practice, Jonathan does. But if you have independent prescribing, I suppose, authority, then you could make a decision to do that. But many pharmacists won't do that if it's not within an area of competence, because you need to be professionally competent. And as generalists, what we tend to be doing, and Jonathan's a great example of that in the community, is he's using his generalist knowledge in the area of common clinical conditions and really pushing that on. I think when it comes to, you know, if you're getting into different areas like diabetes, cardiovascular, you would need to have a certain level of expertise before you could do that. And that's not something that a pharmacist would take on at this minute in time. So it would be, you know, having a chat with the patient, understanding that, and then referring back to the doctor, hopefully, and having a conversation with that GP to get the changes made if it's appropriate that the patient desires.
Jonathan Burton.
Yeah, I mean, I think this is all, again, about making the best use of people's skills wherever they're practicing. So the utopia here for me is, as a community pharmacist, what I'm good at is doing lots of high-quality brief interventions. I'm a spotter. I can spot things because I know patients, and I can see patterns, and I can see when something's not quite right. What I don't currently have the ability to do, and this is going back to the transformational change and looking more at package of care rather than just package in terms of contract remuneration and the structure of the service, is I don't always have the time, or sometimes may not have quite the expertise to fully and completely deal with the issue that I've recognised. But what I'd like to see going forward is more partnership with our pharmacist colleagues working in GP practices and indeed GPs, because there's a number of magic ingredients there. So I'm the guy who knows the patient well. I can spot where there's maybe an issue or possibly an issue on the horizon. I can communicate with my GP practice colleague who can maybe do a more in-depth review of that patient's medication or my advice, and possibly liaise closely with the GP. So we should be working together on these problems. My expertise is like I said, it's being a spotter, it's dealing with acute conditions, it's having a public health role, and being able to make appropriate referrals where needed. Where my GP practice colleague is going to come in is going to be where they need to do the sort of the deep dive into somebody's medication history. It might be a really complex patient. They can work more shoulder to shoulder with the GP on that. I think that's a good combination if we're looking at tackling medicines related harm and unwanted prescriptions, which I think was the core of your question, is how do we deal with these prescription items that are slipping through the system that actually probably need a bit of what we would call de-prescribing attention. But it's not just about stopping things, it's making sure that we make the right decisions and that patients are on board with that as well. And that needs a bit of teamwork, and for teamwork we need to be linked up. So it all goes back to the sharing of records and being able to share messages and have conversations easily.
Thank you very much.
Okay, that's really helpful. Can I ask secondly about social prescribing, because we are getting our heads around as a committee social prescribing and the emergence of that, particularly in GP surgeries. But in terms of your professions, whether that's dentistry, whether optometry, or indeed pharmacy, that actually is alongside delivering the treatment that you would offer in a dentist surgery or the medication you're dispensing, that you would make tacit recommendations or explicit recommendations to say, actually, you should try and get at least an hour's physical exercise a week or more, change your diet, that kind of thing. Is there do you feel encumbered by a sense that you're there to provide that one service and overreaching, or that social prescribing would be overreaching in that case?
Having been in the same practice for a long, long time, and seeing people every 6 months over 30 years and seeing their families come through, that's exactly what we do every time we see a patient. It's just not recorded, it's not funded, but it's something we do as part of a family dental practice. We feel it's, as a healthcare professional, it's not just about dentistry. You have to give people advice on exercise, you have to give people advice on mindfulness if they're struggling at some point in their life. There's a whole raft of stuff that's going on out there that's not measured.
David, quickly.
A really interesting point. I feel that amongst our colleagues, particularly more recently qualified ones, it's a line that they wouldn't feel they would have the mandate to step over. They're obviously, we're walking around the head and neck, and there's lots of things we see, but in addition to that, if you are a clinician of any kind, you're going to be able to, you're in a position to comment on whether people smoke or whether they have a healthy lifestyle. But I think we would require the mandate. I think it's something we would heartily embrace, but I think we need the mandate, possibly from our own regulator as well, to see whether it's something that we're in a position to comment upon. But I think it's a really good point.
Yeah, I think certainly we have a public health element to our contract, so smoking and sexual health, etc. But that probably takes it on a step further, what you're describing, Alex. And you do have those type of conversations as part of your short, sharp intervention that Jonathan says. But I think I would probably echo what both Davids have said. It's not something that's measured. It's not something that's necessarily recorded. It can come up informally as part of a discussion, a wider discussion. But if we wanted again to bring that in, I think we'd probably be able to. But it's again giving us that capacity to do that, and that would require probably longer consultations, etc., and things like that as well.
And Jonathan Burton.
Yeah, I think there's two aspects to this, which I guess could both be labelled social prescribing. One is, do we need more structure? Do we need more regulatory sort of backup for that type of activity? But the second thing is, do we just need more time and space to develop those relationships with the patients that we look after? Because actually it's about trust. If people are going to listen to you, they need to trust you, and that trust sometimes takes a little bit of time to build. So, you know, having supportive practice structures that allow people to stay in one place for a significant amount of time, get embedded in their community and develop those relationships, and having contractual arrangements that give us that little bit of extra time that we need with our patients, that could be equally as impactful, whatever you label it.
Thank you very much. Our final brief questions from Brian Whittle and Emma Harper. Brian.
Thank you. If I may go back to, I think a very important point that it came to me out of Dave Stewart's intervention there is around workforce planning. We heard evidence in the committee around the fact that the 800 GPs that are now being sought by the government, that there wasn't any real methodology in how that was achieved. We then heard from AHPs to say that we know the impact that AHPs can have within primary care, especially within GP surgery. There's no audit of AHP numbers. We don't know how many they are. And then we hear evidence from yourselves that through dentistry and pharmacy and optometry that we don't know how many hours are actually being supplied. How on earth can we have an effective workforce plan if we actually don't know the numbers that are involved in clinical activities, and therefore how many we actually need? How can we possibly plan if we don't take all of that into account?
David McCall.
I think it is possible within dentistry. I mean, everyone who works within NHS dentistry in Scotland has an NHS list number. And we all have to have what's called a combined practice inspection every 3 years. We could collate all that information to see how many hours are being worked. The problem we have seen is when we interact with secondary care, they know roughly how many hours are being worked within primary care dentistry in general dental practice. But in secondary care, they don't know who's doing what, they don't know where they're doing it, and they don't know how many people are doing it. We find that incredible as primary care because we think secondary care is a really, really controlled environment. They're all salaried employees, and we can't understand why they don't know who's working where and how many people they have doing it. So I think in primary care it could be done.
Okay. Very much. David, quickly.
I with optometry, centralised listing will make a huge difference, and because 99% of all episodes go through EGOS, then we know exactly how many patients we're seeing and what kind of appointment there are. So we have that information. Once we have centralised listing, we'll be much better placed because the two sets of data will allow us not necessarily to know precisely, but at least we'll have an idea of how many clinics are being delivered through the numbers of this. The spread of appointment episodes is quite narrow. We know pretty much what would correspond with one individual clinic. So once we have that information, it'll be much easier.
Matt Barkley.
David's actually just reminding me of something. I mean, Jonathan mentioned earlier in terms of the information gathering that we've had through a couple of iterations of workforce surveys in community pharmacy. But what has been mooted in the past as well, which we're supported of at Community Pharmacy Scotland, is the concept of performers lists, which is well known in GP land as well. So that would maybe help to a degree to understand who can do what and where they are in terms of, we don't have anything like that at the minute as well at a health board level even. So so I think it's difficult at the minute with the movement of pharmacists and technicians across, I suppose, the interfaces and within primary care at the minute to get a handle on exactly what we need. But I think again, back to David McCall's point, I think it can be done.
Okay, Jonathan Burton.
Yeah, I mean, I think it's fair to say that the change in the workforce in pharmacy is very rapid at the moment, and that's one of the issues in itself. But I think we're in an information gathering stage. That's quite obvious, but there is very little sort of, I guess, planning that's coming after that. But what we need to look at is not only how many people have we got and where are they, but what are they doing. My working day has changed immensely in the past 3 or 4 years. We operate a mixed consultation stroke dispensing model. The more complexity you see, the more unpredictability there is, the more time you're with the patient sat in front of you. My colleagues in GP practices, what exactly are they doing? Is it administrative? Is it technical around prescribing? Is it clinical review? how's that picture looking at the moment? So I think we need a lot more. We need a lot more granularity, a lot more detail.
Thank you very much. And final question. Emma.
Thank you. I will try and be quick. We've talked this morning about public health and prevention and collaboration and having IT systems that are wonderful and talk to each other. But that's about people then coming to you as dentists, optometrists and pharmacists. What about the folk that don't access healthcare? There's another challenge there when we're looking at poverty and the folk that actually really do need healthcare and health inequality. I'm thinking about the inverse care law. So how do we then get those people to get the support that they need then?
David McCall and Jonathan Burton.
It's a very interesting one. My practice is in Govanhill in Glasgow, and it's a very deprived area. We've had many challenges over the years. One of the ways that we've picked up these people who don't normally access dentistry is the Child Smile programme. So they come in and they get advice on toothbrushing and diet in a non-clinical environment. So the parents are bringing them in, and then because they see how the practice operates in a family-friendly way, they end up making appointments themselves. And I think these people wouldn't ordinarily access the service. So I think it's all about prevention. It's doing something in a non-invasive way outside the clinical environment. I believe that's how we can get people in.
Thank you very much. And Jonathan Burton.
Yeah, if you look at the distribution of community pharmacies across Scotland, we are distributed more heavily in areas of deprivation. Now, there may be some historical underlying reasons for that, perhaps higher dispensing volumes, but that creates a real opportunity and one that is being partially exploited at the moment. When you look at the ease of access for services like minor ailments and the number of children who are treated through that service, that's a massive opportunity to interact with families that are in low income brackets. We have pharmacists working with the homeless, and we have a long history of close working relationships with substance misuse clients and services as well. So we're in the trenches on this one.
Okay, and finally, David Quigley.
Yeah, I think it's just breaking down the barriers, the things that actually prevent people from wanting to come in. I think with optometry, there's maybe been the suggestion that if for example it's non-medical and you require a visual correction, then there's a cost associated with that. I think as well, obviously the NHS provides for persons who are eligible to provide that free of charge. So I think it's breaking down the barriers and making people aware that the provision is available and it's free.
Excellent. Thank you very much. Can I thank all our witnesses for a very full evidence session. We will suspend briefly and resume in a few moments with our next panel. Thank you very much. Resume our meeting. Can I remind everyone once again to ensure that mobiles are off or on silent, and please not to take photographs or record proceedings. After our first panel this morning, delighted to welcome the witnesses for our second panel. Dr Andrew Buist, Chair of the Scottish GP Committee, BMA Scotland, Dr Kerry Lunan, Chair of the Royal College of General Practitioners Scotland, Dr David Hogg, Portfolio GP from the Rural GP Association of Scotland, Karen Murphy, who is a member of the Rural and Remote Patients Group and a signatory of a petition 1698 on medical care in rural areas, Dr Anne Mullen, Chair of the Deep End GP Group, and Dr Amjad Khan, Director of Postgraduate General Practice Education at the Scotland Deanery, NHS Education for Scotland. Welcome to the committee. I'm sure you will all have been following at least some aspects of our inquiry, and you'll know the scope of what we're seeking to do, which is to look a generation ahead for the to answer a range of questions on the future delivery of primary care. And you will have heard, I know some of you were in the room for the last panel when we heard from some of the other health professions involved in the delivery of primary care. So can I start by asking each of you what you see as the role of the GP as a senior clinical leader, as it's been described within multidisciplinary teams, and how that is how your view or your vision of the role of the GP works alongside the role of other professionals within the multidisciplinary team. Andrew Buist.
Thank you, Convener. I would refer to our new GP contract, which started last year. Our aspiration is to allow GP more time to be the expert medical generalist. We have always been the expert medical generalist, but too much of our time has been taken up doing things other healthcare professionals can do as well or better. So our job should concentrate on dealing with people who are unwell, and we don't know why, because we are experts in diagnosis. We should be spending our time in looking after complex care, that is patients in our increasingly ageing population who have multiple long-term conditions, who are best looked after by generalists. And thirdly, being part of a multidisciplinary team based around the practice with nurses, pharmacists, physiotherapists and other healthcare workers working closely together to improve patient outcomes.
Thank you very much. Can I ask for other views, contributions? David Hogg.
Thank you very much. Yeah, just to clarify, I'm a portfolio GP now in East Lothian. I'm still a member of the Rural GP Association of Scotland and was chair, particularly when the contract was being proposed and going through. And that's after 9 years as being a rural GP on Arran. So I just thought it'd be helpful to give that context. I think that GPs, we talk often about the hub and spoke model, both in terms of delivering and designing primary care for our communities. And particularly in rural areas, GPs are often the hub that kind of helps to network up what assets are available in that practice. So I think GPs have a pivotal role in being able to have an oversight. We see everything and anything of all ages, of all types of presentations, from mental health to acute medicine, and indeed the rural context that would extend to emergency care. And so having that oversight and that perspective of how we can design an effective primary care model that includes our colleagues in all other kind of sectors is where I think the strength of the expert medical generalist particularly applies.
Okay, thank you very much. Dr. Kerry Lunan.
So I'm Carrie Lunan, I'm a GP in a deep end practice in Edinburgh, and I think that the role of GPs as senior clinical leaders is a very wide one. So a lot of it is around the clinical role, which is seeing the patients who've got the most complex health and social care needs and providing a holistic model that tries to address people within the context of their own lives and their own communities. But I also think there are many other possibly less measured roles that GPs provide within teams. So particularly as our teams expand and we work more closely with multidisciplinary teams, our roles become increasingly about mentorship and also about teaching and training our future workforce. So we have a very crucial role to play in teaching medical students and to influence them, to make them want to become GPs. We know that's one of the the main factors that influences medical students in terms of whether they choose a career in general practice is having adequate placements out in the community and positive role models that they can relate to. So teaching is a big part of that, training is a big part of that in terms of being able to train our future workforce, but also in terms of the other roles that we provide within the community. Often we are coordinating care across multiple interfaces, not just health, but health is a big one. So between acute and community settings, across health and social care settings, between in and out of hours settings as well. So there's a wide range of roles that GPs play in terms of leadership. And I think in terms of the patient-facing roles, I think a really important role of general practice is also the advocacy role that they play on behalf of their patients, particularly when they're patients that don't necessarily have a voice, a political voice, so particularly around areas of health inequality. I think in terms of how we make that happen, there's been some discussion around growing the GP workforce alongside growing the MDT, the multidisciplinary team. But I think that what supports those teams to work well is having adequate IT so that we can communicate safely, efficiently and well with each other. But I think we can't underestimate the importance of building relationships within teams, particularly new teams that have not always worked together in this way. So I think unless there is time that's protected for people to come together and learn and understand each other's roles and remits, then it becomes fragmented and less productive and less positive than it could be. So I think time is really important as a factor.
Okay. Anne Mullen.
Just building what, hello, thank you for asking me along as well. I'm just building on what my colleagues have said. I work in a deep end practice in Glasgow and I chair the GPs of the deep end group. And I would agree with everything that has been said up until now. I think that GPs are holistic practitioners that provide family-centred medicine over a number of generations. I think we've always worked in teams, historically in general practice. But I think it's very important now with the complexity of healthcare that we begin to understand where we are in that complex system while protecting and maintaining the resilience of general practice as a profession, because continuity of care is extremely important and probably pivotal. The gatekeeper role of the general practitioner is extremely important to the health of other aspects of the health service, including acute secondary care, and indeed our associated teams that we work with, social care as well. And I suppose the SHIP project that hopefully we'll maybe talk about later on provided detail of what that would really look like and how we worked our way towards that. And I think in deep end communities, obviously the challenge is to deal with all the issues that contribute to health inequity. You know, we're not all born equal, we know that, but there's a lot the system can do to make health inequity equal. And I think that's our challenge in deep end communities where there's such a concentration of deprivation-related issues.
Thank you very much. Can I ask then, given what you've said in particular, I think Carrie Lunan referred to the need to understand how other professionals worked or to have working relationships with other professionals. How far do you witnesses feel that that's the case at the moment? Because the Scottish Government's vision for primary care is very much around multidisciplinary teams. I think a number of you have said there has always been a team approach, but clearly the vision is for a development of that team. How far is that? Is there mutual understanding there and what needs to be done to improve it? David Hogg.
Thank you for that. Yeah, I think that obviously I'm leaning heavily towards my experience in rural practice just now because I was 9 years on Arran. We work very closely with our colleagues, partly because they are part of the community. It's the usual sort of rural situation, you're wearing multiple hats. So, but in particular, I think as rural GPs, like other professionals in the community, we often do wear the hats of their service as well, and that's not to kind of claim that we can do anything, because it's a lot about kind of cross-boundaried professional competencies. What I mean is that when I was on call in Arran, I would be the pharmacist. I would be taking requests for medication in our community hospital from holidaymakers who'd run out of medication. I would be called out by the ambulance service saying, the ambulance is already busy, or we don't have a paramedic crew on today, could you go out and be the paramedic? Or could you, we've got, because of things like the Scottish STAC agreement, which has caused real problems in district nursing provision and out of hours. I've been through times when we've had no district nursing provision overnight. That was a regular occurrence. on an island, it then comes back, well, who else can do that? And that becomes a GP. Now, we serve our communities. It's an absolute privilege to be a GP. And I'm sorry that in the current contract discussions, it seems that we've had to kind of highlight some of the negatives or the concerns about primary care going forward. I consider my role an absolute privilege to be a GP. We want to serve our communities, and that means we do have to help out our colleagues, as sometimes we do to them. But the strength of rural practice, right back, if we look over history, right back to 1912 and the Dewar Report in Scotland, the rural areas are great ecosystems for understanding how we can deliver team-based primary care. The Dewar Report in the Highlands and Islands was the blueprint for the current NHS. And we're very, very ready and waiting to see effective and realistic aims for expanding the multidisciplinary team model. But we have to see that being realistic. And that's where the concerns from rural GPs, where we have flagged up, we don't see things working, certainly not as fast as is being claimed or anticipated. That's where we've got the kind of the concerns.
Okay, thank you very much. Carrie Loonan and Andrew Bruce.
Thank you. I think in reality, the experience of how well teams gel and understand each other's roles is pretty variable across the country, and there's lots of different reasons for that, but there seem to be some themes anecdotally in what makes things work well. So I think when teams are involved in the creation of their teams rather than people being placed in organisations that they've not necessarily chosen in areas of Scotland that they wouldn't necessarily feel comfortable working in, then that feels like it's immediately quite a difficult start. So I think involvement in the kind of recruitment process, involvement in the interview process, and then involvement in the induction process is really important to make sure that people feel valued and part of the team and that they are chosen and they have chosen to go there. I think that in addition to that, what can make it feel, people can feel more understanding of each other's roles is if you can do formal things like work shadowing of each other's roles. Now that probably happens less across primary care teams than it maybe does across medical teams between, say, hospitals and the community, but we're very keen on that idea, that model within the college to give a formalised structure to spending half a day walking in each other's shoes and then formally reflecting on what that learning is all about and bringing that back to your team, because I think there's nothing that substitutes spending time with someone to understand what the challenges are in their role and then looking at how your systems might be impacting on them and vice versa, because that often creates some quite easy wins in terms of making things better. I think the other thing that is really useful to think about is interdisciplinary teaching and training. So if there are medical students in the practice, making sure that they shadow all members of the team, including out in the community, and also medical students learning medicine. I think there is more of a move towards where learning is core, generalism, to sharing that. But I think the other thing that can sometimes stress teams is the external factors that we can be subjected to, particularly in the media, when there's coverage around GPs being replaced, which is not helpful for anyone because it makes everybody feel uncomfortable. This is more about collaboration rather than substitution. But when the headlines are all about substitution, then it's not helpful because everyone then starts to feel uncomfortable. And when you get together with primary care professionals, as we do every few months in our primary care clinical professionals group, which is a bit of a mouthful, but it's a really useful group, often we will talk about our common areas of interest and how we challenge the sort of negative rhetoric around the wider MDT and each other's roles.
Okay, thank you very much. Andrew Bruce.
Thank you. I mean, in terms of where we are, we've always had, most practices have always had district nurses and health visitors, but we haven't always had pharmacists or physios or mental health workers within our team, so that's new. As Gary said, where we are just now is variable across the country, but it is developing. It's going in the right direction. One of the rate limiting steps in terms of the rollout of the contract is the availability of the new workforce. We are short of pharmacists, we're short of physios and advanced nurse practitioners. But they're coming into practice, and once they're in the same building and you meet with them on a regular basis, they're part of the team. You share patients, you share the kettle, as I call it, in terms of having a cup of coffee with them to discuss patient care, and that sort of breaks down the interprofessional barriers and allows you to progress.
Okay, thank you very much. There was a mention of interdisciplinary teaching and training, and I wondered Amjad Khan, if you would want to comment on the role of that in promoting the multidisciplinary team.
Yes, thank you, Convener. Just to say the GP role and the role of the GP in the primary healthcare team is essential, and a successful primary healthcare team is essential for the whole NHS. So it's in our interest to make sure that the team works well and that we all know what each other we're doing and understand all our each other's roles. Interdisciplinary training and teaching is essential for that to occur. At NES, we're interested in making sure that there is capacity to do that within primary care, and that's one of the issues facing it. We're trialling out things in the near future to ensure that there's the capacity to train pharmacists, paramedics, and others to increase that provision.
Okay, thank you very much. Thank you very much. When we've been talking to members of other professions, whether it's the ones that were in this morning or those from which we heard last week, there is a sense that there is a risk, I guess, in the fragmentation of care if people are being treated by different professions, and also a risk that patients may get lost in referrals between different professions. Would any of the witnesses wish to comment on those risks and how those might impact? Andrew Buist.
I mean, I come back to my point. If the team is built around the practice, if they are all based within the practice, then you're coming into contact with these other healthcare workers on a daily basis, rather than them being, you know, half a mile down the street in another building. So I think that is really important. That the hub, as David called it, the primary care team is based within the hub, so that there's that interaction between different healthcare workers, which will avoid the risks that you describe.
David Hogg and then Carrie Loon.
Oh, thank you very much. So, yeah, I know that there's a lot of talk about connectivity and IT, and it almost becomes a bit of a cliched answer to how do we work better together. But as GPs, we're still waiting for our GP system to be updated, which I believe is significantly late. And I think it has to be highlighted that if we're moving towards an MDT model of care or an enhanced model of MDT care, which we're all really signed up for, it makes sense. We like working with our colleagues, and I think our colleagues like working with us. We've got a lot to learn from each other. But one of the big barriers just now is IT. I can't even email a consultant without doing that from my personal email. So his reply, instead of going into the patient's notes, goes into my inbox. If I'm locuming in one of the practices in East Lothian, or even in before an hour, there's a clunkiness to it. And if we're really serious about working together, we need to work out how connectivity and IT can help those interfaces. And that's an example where there's a despondency, because we're still waiting for this new GP provisioning project to bear fruition. But it really is a key part of letting us move forward.
Carolyn.
Thank you. I think that I suppose one of the things that we're talking about here is the importance of continuity versus the importance of managing workload. And it's a difficult square to circle sometimes, because we do need to be able to share out the clinical needs of a population according to the person that's most appropriate to see them, where it's safe and effective to do that. And I think that's a really important part of the model moving forward. But there are some patients who really benefit from continuity of care. They're often the frail elderly, they're often people with very complex social problems or very difficult to manage long-term conditions or dual diagnoses of, say, chronic pain and addiction. So they really benefit from having a named clinician. Doesn't have to be a GP, but it often is in reality a GP. And I think that we know that continuity saves lives. There's a lot of evidence now that shows that continuity saves lives. So if you know someone over a period of time and you've built up a relationship of trust with them, you're more able to you engage in shared decision making with them. You're more able to deliver realistic medicine because you have a better understanding of what their values are. People are more likely to disclose what they're concerned about earlier on if it's somebody that they know from before. So continuity is not just a nice thing to have that people like. It's also important in terms of people's morbidity, people's mortality. It does save lives. So I think what we need to do as we expand our teams is we need to have every single safety net in place to make sure that the information is still captured and that clinicians can still speak to each other about the people that they're worried about. And a lot of that is IT, and a lot of that is time to build teams and have meetings and discuss complex patients.
Thank you very much. Anne Muller.
I think Carrie hit on a point there, and extra time for us is absolutely crucial. Extra time allows you in deep end practice and elsewhere with their pressures with whatever complex needs your patients have to provide empathetic care, the kind of care that then prevents perhaps unscheduled admissions, can pull fragmented systems together. It gives you time to be a leader within the practice and within the cluster, wherever it has to be. But these relationships, which are really dependent on good communication skills and continuity, do depend on GPs having that extra protected time, which we demonstrated in SHIP. And with all that work, we started to affect demand in terms of GP demand, because we were addressing patient needs in a sort of coherent, cohesive way with the other set, not necessarily us, perhaps with housing or whatever service, mental health needed to get involved, social services crucially to a lot of the cases. And time is never factored into health economy. It's never factored as something that's important, and there should be a cost within that.
Okay, very important point. Amjad Khan.
Yes, continuity is important, as we've already heard, not only for good patient outcomes, but more importantly, even for job satisfaction. Our trainees tell us continuity is important to them, and I think if we were to have a successful general practice and have more people working within it, I think they need that sense of being valued and have the job satisfaction which continuity of patient care brings.
Okay, thank you very much. David Torrance.
Thank you, Convener, and good morning, panel. What are the current barriers to data collection on primary care cost, activity and demand?
A couple of witnesses have already mentioned the importance of IT. What barriers should be highlighted here? David Hogg.
Trust. I think that is what underlines a lot of our current concern. Because frankly, the experience that we have is that whenever people are asking what we do, particularly health boards, it feels like it's often with an aim of taking something away or working out what you can do without. And that's based on experience, not just of myself, but more so listening to my colleagues, not just those who have contacted more recently to kind of check that my current perspective is up to date, but also 9 years, and also as chair of our GPAS, the Rural GP Association of Scotland. A lot of my time has been spent on the phone listening to the concerns of those, and we're currently going through a particular data collection exercise just now to try and tease out income and expenses for practices. This is public money. This is really important that we are accountable. This is really important that we work out how we get value for money for the taxpayers' money. There's no doubt about that. But the mechanism, and in our report, looking at the right map, which was our direct list of suggestions and constructive suggestions for when the contract proposal first came out, in the middle of the triangle that we used to summarise our concerns was trust. I can go into examples, I don't want to impinge on others' time, but for me it's trust and knowing what people are going to do with that. We're very, very aware this is important money to work out how we're spending, but in previous times information has been misused or misrepresented unhelpfully, and that places a lot of practices in the back feet. We know that independent contractor models work. It costs 2 or 3 times more to run a practice if you put in a salaried service, because as a GP partner, as I was in Ireland for 6 years, you have an accountability to your community, your colleagues, and also to the health board. So you work out how to make these efficiencies, and we've got direct management of our teams, which is really important. To tie that in very briefly to the MDT side of things, GPs like to have that kind of degree of trust with colleagues. An MDT rollout, which doesn't involve GPs as being able to shape and determine how MDT rollout will happen for the communities, again brings back the element of trust. This is our community. For some people, it's my colleagues' children, it's my colleagues' relatives, my colleagues' kind of spouses, who are directly influenced or affected by how they can access healthcare by the same people who are providing it. So I hope that answers the question. For me, it's trust has to be restored.
Unknown.
I mean, I think there's an issue with joined-up thinking across health. Health is becoming very siloed itself, with in-hours general practice, out-of-hours, primary, secondary care, all the other services that come into that as well that are part of the primary care team, and the GP hub and how through the HSCPs we start to connect with other services in a way that's consistent across the piece. So I think that, you know, the problems that we see in out of hours care that spill over into A&E referrals or people walking to A&E really have roots in probably in-hours general practice, which itself is under stress because of all the issues we've talked about. So I think that, you know, that the planning, I don't see the joined up planning being done yet. And I don't see impact statements on if in-hours GP is struggling to provide a service, what that means for out of hours. And then if out of hours struggle, what that means for A&E. So you need, I think, better, more consistent joined up planning.
Carolyn.
I think I agree with everything that's been said so far, but I think coming back to the IT infrastructure in general practice, it's again very variable across the country with lots of differences across health boards, which makes it difficult to then roll out data collection tools such as Spire, which would be very useful in being able to look at how we plan our future healthcare services. But there are swathes of health boards that aren't able to use that yet because the IT infrastructure is not up to speed. So I think investment in the kind of basic functioning stuff is really important to get the data, which is really important to be able to inform services, because otherwise we tend to measure the things that are easy to measure. So we measure the number of people that turn up to A&E, and we measure the number of bed days that people spend in hospital, and we measure the number of unscheduled attendances and admissions to hospital, but we don't have very good data around primary care at all. Out of hours is better than in hours, but in hours data is really poor, and without the data we can't demonstrate the work that is being done, and we can't show what we need to improve. I also think that there is a key role here for the GP cluster model, and for GP clusters to be as up-powered as they can be, they need to have project support, they need to have data analyst support, which they do have. They also need to have administrative support, and they probably need to have much more support with evaluating the ideas and the projects that they are involved in. Now, their role is to determine what quality improvement work needs to be done at a local level, and it's based on the needs of the local population, and each cluster represents, say, 6 to 10 practices with one GP from each practice coming in to do the quality improvement work. But this is the future of quality improvement, and it should be hugely informed by local data. So there are, I think, up-powering the role of clusters and making sure that the new guidance that's just been launched is embedded and enacted is really important.
Amjad Khan.
Brief point on that is, as a GP, when I was asked for data, it was always made it worthwhile if I knew what it was about, what was going to be done with the data, what was the reason for the collection. So I think if information is given as to why we're collecting something, why it is important, then that would help. And secondly, just to pick on what Carrie had said, not everything is countable, because you can be seeing a patient. Yes, you can count that you've seen 15 patients, but actually some of those have not required a prescription. You may have spent half an hour with somebody who's had a death in the family. And how do you count that in terms of counting? So I think all data isn't equal, and we need to be clear what we're collecting, why, and what the purpose is.
Okay. David Torrance.
Thank you again, Kavina. You mentioned, Dr. Hogg, that you're in the process of collecting data around expenses and costs. When do you know if this will be completed? What timescale?
So it's not me who's collecting it. This is I understand that the exercise has started from Scottish Government and SGPC to start to ask practices for that information. Dr. Bewes would be better placed to answer that question. If that's okay.
Thank you. We're just about to put out the data collection programme to all 950 practices in Scotland to get information on their income and their practice expenses, and also their practice workforce, how many hours everybody does. So that should be going out this month. They'll have about a month to return it, and ISD will be analysing that data from about December onwards, and hopefully we will have the first cut of that anonymised information to the Scottish Government and the BMA early in next year, and we will be using that information to begin modelling for what we're calling phase 2 of the new contract.
Okay. Thank you very much. George Adam.
Just a very quick one. Good morning. It was on what David said regarding salaried GPs being 2 or 3 times as much. Now, I'm assuming when you say salaried GP practices, you mean board-employed GP practices. Now, we've been told that you can't quantify that figure. We were also told that GPs would say that, but we were told that you can't quantify this figure. Now, do you have anything that you could possibly provide the committee that does quantify that, or is it just something that GPs say it's 2 to 3 times more?
I understand that the evidence for that comes from work through Scottish Government, through Richard Foggo's team, and I think, again, Dr Bewes might be better placed to comment specifically on that. What I can offer the committee, and I'll be short on this as well, because I know that time is important, but there is experience, again, speaking to colleagues, not just in Scotland either. I've been lucky to enjoy speaking to and collaborating with the international rural stage. And there's, when you look internationally, you can the international stage is ripe for lessons about different funding models for primary care in particular. What I can say, so at the end of 9 years of Aaron, I totted up what I'd actually done, back of an envelope type job. But this was 9 years in Aaron as a GP myself, and I think this equivalates to what most GPs are providing in rural areas. 22,000 GP consultations in that time, 610 nights on duty, 384 ward rounds, 152 basics, pre-hospital emergency care requests when the ambulance service don't have a suitable resource to send to something. They were all voluntary. 129 weekends on call and 59 medical students taught. And I think what I'm trying to say to some extent with that is if you have valued colleagues, if you have valued clinicians working in rural areas, working effectively in teams, you just get so much more synergy from that. So the amount of goodwill, the amount of, for example, the basics calls is a good example there. I don't get paid for them at all. It's because I want to serve my community and it makes sense. And when I'm paid as a GP to oversee delivery of Aaron Medical Group services, as I was for 6 years as a partner, along with my 5 other colleagues at the time, you have an investment in your community. And when you start to detract from that, it means that when you're at 5:15 and there is an issue that has to be sorted out, you just have a bit less ownership, a bit less control, and a bit less kind of drive to sort that out at the end of your day. When, frankly, when you're salaried, you've got a bit more clout to be able to say, sorry, I'm not responsible for that anymore, I can pass that on to someone else. I think that's what we've lost, or what we're at real risk of losing if we bring in more and more salaried or 2C health board run practices.
I wasn't questioning anyone's professionalism. All I was asking was we need to have the actual audit trail and follow the money, because we still don't know. You've not really told me why it's 2 or 3 times more for a salary.
So that's based on discussion, so I'm happy to, sorry.
That over to Andrew Boost, I think, might be more.
I mean, I agree with everything David Hogg said there, and promoting the partnership model is a key driver behind the new GP contract, because we know it's good for patients, we think it's good for the taxpayer, and by and large GPs prefer it too. We can provide you with the information you're seeking, George. The information I've seen so far is that 2C or salaried practices to the board tend to be about twice as expensive, although there is always a suggestion that the management costs that are provided by Health Board are not fully included. But these practices will be included in this data collection we're just about to embark on. There's also some evidence that the indirect costs from these practices are higher too, in that sometimes referral rates are higher from salaried practices than from GMS practices. But we can provide you with more detail on that.
Thank you.
Okay, thank you very much. Emma Harper.
I think Dr. Lunan answered my questions about clusters, because I was thinking about GP clusters. But I'm interested in, further exploring really what are GP clusters and how can we make clusters work better, especially in rural areas such as in the Vrees Galway part of the South Scotland region. So I'm interested to hear a wee bit more about whether the clusters work, how they could work better. Do we need more structured approaches? What is it that we're looking for as far as outcomes from clusters?
I think in terms of what are clusters, they are essentially groups of practices coming together to share learning and ideas and data around what needs to be improved at a local level, depending on the needs of the local population, as a kind of very big concept. And they are the main driver for quality improvement in general practice since QOF was abolished 2 or 3 years ago under the contract, the Quality Outcomes Framework. And the intention is that every single practice is involved in quality improvement by having a dedicated GP within the practice who works with the wider team to do quality improvement at a practice level and then feeds that in at a cluster level so that there is more learning across clusters. I think in reality, clusters are still quite a new concept. They've been running for 2 or 3 years, and we have a group of 3 GPs called local advocates that have been going out and doing outreach work with clusters across Scotland, basically to go out and try and find out what's working well, what's not working so well, what could be done better. And I think that clusters essentially have 2 main roles. One is an intrinsic role, which is about building relationships with other practices, sharing learning, sharing ideas of innovation, troubleshooting locally. And one is an extrinsic role, which is about influencing bigger systems, so feeding into health board structures, IJBs, health and social care partnerships to try and influence and improve at a local level. And in general, and this is a generalisation, the intrinsic functions are working quite well because people can naturally do that quite easily, but the extrinsic functions are proving to be more difficult because these are about building new relationships across interfaces that have maybe historically been more difficult to broker. And in terms of what would make clusters more powerful, more influential, I think a lot of it is to do with allowing them the time to meet, allowing them the time to be involved in meetings that allow them to fulfil their extrinsic roles and be consulted as a professional advisory group more. They suffer from a little bit of mission creep in that I think that a lot of people feel clusters are going to save the world, and I think they would love to save the world, but they don't have the capacity to do that, so they have to be quite strict about what they can and can't take on, which was one of the reasons why we, together with SGPC and Scottish Government, created some guidance along with other stakeholders about what is the role and isn't the role of a GP cluster and how could they best be supported. And some of that is about resourcing their time, some of it's about giving practical supports to clusters. Thank you.
Anyone else want to comment on that? David Hogg.
It's just the question was asked specifically as well about implementing or enabling clusters to function in rural areas. Just to echo the other points, it's time and it's resource, and freeing clinicians up to either be able to attend with good connectivity, video conferencing, or indeed to be able to travel to meet each other. That is pivotal. But I think the other thing is to allow the cluster model and the concept to evolve. It's very difficult to put a group of people together who someone else thinks they'll get on. And it's kind of almost like sort of planning a dinner party, do you know? It's important that clusters can evolve and clinicians can find for themselves where they're going to get most benefit. It's important to have access to colleagues in similar kind of settings, but also to have the kind of the spark from kind of where new ideas might kind of come from. So I think allowing the cluster model to develop, it's felt a bit top down so far. And I think that working out how we can support rural colleagues to access that, it comes down to time and resource. But I think that hopefully answers your question.
I'm just wondering about, like, cluster model, would it be about sharing allied health professionals? We hear about the evidence that was submitted to that a lot of people attend GP practices for mental health needs or mental health assessment, and so there's issues around the 10 minutes versus 15 minutes in order to assess a patient. Or is there a better ask for psychologists to be implemented in primary care rather than secondary care, or even social workers? Bring them out of the local authorities and put social workers in primary care, because that's how we can do a better holistic approach to addressing the needs of the patients.
Anne Mullen.
So the SHIP project did do a lot of that work. We were the GP hub, and we were connecting with services that we thought should be co-located with us in the health centre and not distant from us. So the first year we spent with our developing the MDT, because previously we had an MDT structure, but it was only health visiting district nurses who would discuss a very defined patient group with them. So this was expanding the MDT team into this sort of holistic primary care team that we've talked about at deep end meetings. And the first year was really spent deciding where our territory was and how we would work together. I mean, it takes quite a bit of work to build these teams up, and then to decide who else you're going to connect with. It could be housing, could be third sector, home start, whatever. And that just takes time. So you can't just transplant that into a sort of process and expect it to happen straight away. It's not going to. And I know we talked about data quickly, but we developed localised data sets for the SHIP project, specifically to look at complex multimorbidity, particularly because the ISD data sets give you systems analysis and numbers, but they don't join it up. So that was a really important element of the data collection. And the multimorbidity tool is being used now by other practices in clusters to help them define their patients are probably going to, you could probably predict, are probably high users of the health service, are probably going to need quite a bit of time spent with them planning, etc., and with other organisations.
Okay, I've Carrie Lynn, Andrew Burst and David Hogg.
Just a very brief addition. I think you'd asked Emma about sharing AHPs, and I think that, yes, that in answer to your question, I know that some clusters have felt almost like a collective bravery about trying out something new across a cluster. And so, you know, the cluster I'm part of, for example, has had the great fortune to have a practice-based physio across the cluster and try out new models. So I think that there definitely is scope to try things through clusters. The other thing, just to briefly mention, is that I think moving forward it would be very useful and powerful to see the whole of the GP workforce included in cluster working, because at the moment it's largely practices only rather than locum GPs, sessional GPs, and also out of hours GPs who also have a huge amount to bring into the bigger picture thinking.
That's Andrew Burst.
So thinking about mental health and the cluster, I mean, as an example, the cluster would look ideally at the extrinsic activity of the community mental health team. So a cluster may have 8 practices using one community mental health team, so they might look at the data on the use of that service by their patients. But each practice will ideally have a mental health worker of their own within the practice, within the hub of the practice. And so the cluster will look at the activity within the community mental health team and analyse activity and perhaps suggest improvements that might get the balance of where patients seek the mental health support, whether it's within the practice from the mental health worker or whether referral to the community mental health team is appropriate. So these are sort of evolving improvements that we aspire to have.
Much, David Hogg.
Thank you. So I think it's important to recognise that primary care systems are quite well-evolved ecosystems. They are systems within themselves and often very unique and have been tailored and evolved to meet the needs of the communities. And it's particularly fragile in rural areas where small sort of changes can result in a kind of knock-on effects that are not always apparent. My point here is it's important to enable local clinicians, not just GPs, but importantly GPs as part of that conversation. We know our communities. Not just in rural, but we know our communities in whichever centre we're working in. But particularly in rural areas, there's been a fear that the MDT provision or other provision through the current contract is defined by a kind of a top-level approach. For example, there's a rural GP who's been offered a pharmacist for half a day per fortnight. Now, if they could take the funding for that and say, we don't want a pharmacist for half a day a fortnight, that will make no difference really on workload, on managing GP workload and making kind of the practice more sustainable. That's what this is really all about. But making the services available to practices to then have a say in what they would like and what they feel would most support their service. There's some practices who've already invested heavily in recruiting a pharmacist, in recruiting a counsellor, and some of them are feeling a bit left out because if they've already got it, but it's not been through the top-down approach, then that's not recognised and it's not funded. So we have to recognise the fragility of the ecosystem and give practices the flexibility to deliver and shape services that they know through their contact with patients what their patients need.
Briefly, Andrew Burst.
If
To come back, I went up to Caithness and Sutherland back in August. I went to practices in Lochinver, Ullapool, Brora, Wick and Thurso, and the message David described was one that I was getting, and it certainly struck with me. GP in Ullapool said he didn't want salami slices of services. He wanted a whole person, and I've certainly taken that away, and will give that thought going on beyond phase one of the contract, that rural practices need a different approach. We've always said there would need to be flexibilities in very small and remote practices, so delivering vaccination services in the smallest practices, it will be appropriate in many cases that they're done by the practice. So flexibility in these areas is needed.
Thank you very much. Anne Mullen.
So again with the SHIP, I'm sorry I'm going on about the SHIP project, but we did have a pharmacist who worked between the 4 practices, so it was a shared resource. So I think in urban practices, deep end practices, it can be a shared resource. You just need to have the practices work out together how much of a pharmacist they need and then agreement, and it's achievable.
It's just a wee final comment. And we're actually seeing that welfare and benefits specialists are actually starting to co-locate within GP practices, and that's shown a benefit. I heard a story recently where somebody was prescribed antidepressants when actually what they really need was a debt consolidation specialist, because that's what was causing this person the anxiety, and that would mean then they get the support they needed rather than simply diazepam.
So and obviously with the Pioneer, the Parkhead welfare worker, that's exactly what that was modelled on. And there was obviously a benefit, an economic benefit to everyone, the patients who participated in that. And not just that, the patients themselves, I think when you empower patients like that, when you lift them out of that poverty level, they're empowered as well to use services a bit more, and there's some evidence of that too. I think the challenge is the occupancy, where you'll put the workers, because we have a links worker now as well, and you don't want to duplicate services. So if you've got a links worker, then you have an advisor, a financial advisor. There's a risk as well that you start to fragment all the advice that you have. But again, I think with urban practices, particularly deep end practices, with the concentration of deprivation, that could be a shared resource in a health centre somewhere. So that, I think there are ways around it.
Thank you very much, colleagues. I'm conscious of time, and I want to move on to the issue of the GMS contract and particularly evaluation. The Scottish Government published a primary care monitoring and evaluation strategy earlier this year. Audit Scotland commented there are no measures that would allow the Scottish Government to monitor the direct impact of the GMS contract, including the intended effect on the role of the GP, recruitment and retention, and any impact on staff and patient care. So can I ask, first of all, whether more work is needed or more mechanisms for measurement are needed in order to evaluate the effectiveness and the impact of the new GMS contract? I thought there'd be a rush of evidence on that one. Carrie Lumen.
I'll go first. So yes, is the short answer. And I think that what we have to remember is that the landscape of primary care is changing really rapidly. And we need to make sure that any future models of care are based on evidence, like we do in anything in healthcare. So when things feel good and seem to be working well, that's probably not good enough level evidence to base such a seismic shift on. So I think this is where the role of the Scottish School of Primary Care for me comes in, as a primary care based high quality research organisation that can look at different tests of change, different models of care, and start to measure and evaluate them with a level of robustness that doesn't necessarily happen if you're looking at them in isolation. So their recent conference earlier on this year presented the summary of looking at 204 tests of change across Scotland, and their learning from that was, not surprising, it was that the pilots were too short to draw any conclusions from, and that, as expected, there was a rise in GP workload before you could expect them to be a fall, and you hadn't begun to see the fall. And that rise was around mentoring and training and support and inducting and welcoming new members into the team. and that short pockets of funding can sometimes be more damaging than no funding at all, because it generates a kind of expectation and a hope within a service that things will continue when they don't. So I guess my plea would be that the evaluation has to be ongoing, has to be high level, has to be funded, and has to inform what future models of care look like, because I don't think we do know the answer to a lot of these questions in terms of what will the impact be. We hope it's good, but we don't know that, and there may be unintended consequences such as rising workload in other parts of the workforce, which we need to take into account when we're thinking about how we fund it and monitor it.
Okay, thank you very much. Anne Mullen.
Again, the SHIP project, which has been mothballed now, was a 3-year project from the Test of Change monies, and probably the most comprehensive Test of Change project, because of what we were setting out to do. It was really to build this holistic model through the MDT working, and has many aspects that are aligned with the new GP contract, but the issue of GP time is not really aligned with the contract in that sense as an economic costing. And I think the point of the SHIP project is that it retains older GPs, so we know retiring because they were fed up, and it attracts younger GPs because there was a mentoring going on, and that kind of process has been replicated through the Pioneer scheme as well, which is very important, because you want younger GPs who are not ready for partnership and probably maybe wary about coming to deep end practice. You want to make that experience very good for them, make them realise that with a bit of support they can be deep end GP partners. But the protected time was absolutely crucial in that project, and that seems to be one of the main sticking points, although we do have a costed report on the project that has been accepted by Richard Fogel to have a look at. His team has that. So there is an alternative, and I think we have a lot of data now from the SHIP project, and even though it's a relatively small data set, it's enough to start to make conclusions about the data.
And given what you've described, does the SHIP project therefore come into the category of those things which the health service has tried, which have worked very well, and which then have been set aside?
I would say so. I would say so. And I think the really disappointing bit of it is that it's a holistic process. So you start in year one, and we spent a year working out the groundwork really for the project, and then you build the relationships up, and then they finish after 3 years. It just doesn't, it's illogical. Whereas you want to kind of keep rolling that out, and the base is really the educational process for the other practices that are coming on board. And we did show that we could share managerial staff, we could share pharmacy staff, physio staff across practices in an urban setting.
Thank you very much. Can I take Karen Murphy and then David Hawke?
Thank you. I fully understand the need for evaluation. My concern, and has been for the last 18 months and will continue to be so, is that implementation has happened in phase 1, and that we are risking rural and remote areas in terms of recruitment and retention of GPs, in terms of morbidity and continuing problems for patients. So yes, that's really, really important, and it's good to hear that there's some understanding that it's not, that there's a need for a more flexible approach in rural and remote areas, but from my point of view, when is that going to happen? Because already it has had a detrimental impact. There are questions about mortality. I think Dr. Helen Irvine and Professor Wilson have submitted some information about that. Yes, there's no correlation, but there are indicators out there that for rural and remote areas, there are things that are impacting on patients' lives. And it's all very well to talk about evaluation, but actually what concrete measures can be put in place so that we do retain our GPs. It's wonderful to hear about multidisciplinary teams, the practice that I'm a patient of, and I can only talk about my own experience. It has no health visitor. It has no district nurse. We're reliant on somewhere else for those, let alone wonderful things like, mental health workers and all the other multidisciplinary people. The reason I became so interested in this is because it is so difficult to live in a rural and remote area. Yes, we want multidisciplinary teams. It's not practical, it's not feasible. And if a GP and that sort of service is the best way forward, then we need to hang on to the GPs. If a multidisciplinary approach, because it's a salami sliced thing isn't going to work, then how can we retain and recruit GPs? And to me, it seems like the contract doesn't necessarily do that. It doesn't recognise that particular role that GPs have in a community, and it's such a fine-tuned thing. For me, when I was in my 30s and I moved home, it was really important to me that the schools were there. When I was in retirement, it was really important to me that the GP was there. And anything, and I'm a young, well person, and it's a concern that there are my neighbours and other people in the villages, and presumably in other communities like mine, where that access to healthcare is going to be really, really difficult to people. I sat earlier and listened about trying to encourage people to think about where else to go for healthcare, and the talk about social media, and that's lovely. But I live in a village where information is passed with a poster in a bus stop. You know, it's all fine, high-level stuff that is being discussed, and I can understand it. I can understand it in urban communities. I can understand the need to educate people to go to a pharmacy. But when the pharmacy is 40 minutes away and the bus doesn't run except every 3 hours, you know, it's going to be more difficult. So yes, please evaluate. But what I would like to see, and what the petition was asking for, was for some speedier responses. I mean, secretly, it wasn't to me the short life working group; it was the slow life working group, and we still seem to be in that situation. That's all I have to say.
Thank you very much, David Hogg, and then Andrew West.
Thank you. In fact, one of my points was to make sure that we listen to patients as part of this. And so thank you for taking Karen before me, because you've actually gone through some of the points I was going to mention. Our patients are ultimately amongst the best judges of how services are being run. And for various negotiation reasons, patients were not so involved in the designing of the contract. It was a negotiating position, but essentially this is a contract that seeks to kind of shape the future of primary care in Scotland. So I think it's essential that we have the patient view, and I think it's great that Karen and the people who work with Karen have felt confident to kind of raise the concerns that they have done, particularly to the Public Petitions Committee, and we've already heard some evidence submitted to that. I think we need to recognise that currently the experience is that things are slow, and I think there's fairly good agreement across rural GPs and our medical political leaders. The progress is slow. It was always going to be a big kind of step to kind of see this rolled out, but it is slow, and we have to work out and understand the effect that that does have on despondency amongst clinicians. There's a lot being said just now about recruitment to rural areas, and it's great to see some of these innovations. But the real concern of our GPAS and the real view being expressed is that the best mechanism for increasing recruitment is retention. It's why Australia and New Zealand historically have been so attractive for people to move to, because they see happy, supported GPs and doctors in these areas. The contract has devalued rural practice, and we may have time to go into that, or maybe not. We've already written and spoken a lot about the concerns about that. We are in a situation where a lot of rural GPs are feeling very fragile about what's happening. They've seen their workload estimates, or a measure of the workload they're doing, fall by 82% in some cases over what they're actually delivering. So there's a real problem in rural areas that GPs are feeling devalued. And I think the way to address that, because I want to come here with solutions as well. There was no rural proofing evident, really, or there's a limited amount of rural proofing evident in the contract design, and indeed in other parts of Scottish Government policy. I mentioned the stack agreements for payment of non-medical staff as another good example. Scotland, 20% of the population is rural. 98% of the land mass is rural. Surely we should be aspiring to a stage where, actually in many policies, not just in healthcare, there is a mechanism by which policies and decisions go through a rural proofing process, just like Canada does, just like Australia does to some extent, just like South Africa does very well as well. And I think that was our biggest disappointment, that we've got evidence of things coming through from this contract that have just sidelined rural communities. Not rural GPs, rural communities. And that's where I think there's real kind of mileage to be made in how we take things forward constructively.
Thank you very much. Andrew Bruce.
Just to reassure Karen that the future role of the GP was absolutely central to the new GP contract, as I decided earlier, not just in rural areas, but across the whole country. And a measure of the success of the contract will be GP numbers and seeing those starting to rise. we've seen a fall in GP numbers, a whole-time equivalent, over the past few years, and we want to turn that around. Of interest of the petition, one of the stems of that was to avoid a postcode lottery. This is something that we actively seek to address. I would suggest, rather than avoiding a postcode lottery, there is evidence we already have a postcode lottery of funding in general practice in rural areas. Camila, I know you're from the Western Isles originally. If I can give you three practices of similar size in the Western Isles: North Uist, South Uist and Barra. They all have populations list sizes between 1,000 and 1,500. South Uist gets £174 per year per patient on average. In North Uist it's 230, that's £56 more. In Barra it's £264, that's £94 or 50% more. Now, we don't understand why that is the case. And that is what we are seeking to understand through this data collection that we're just about to embark on. It may be due to the fact that one of the practices has very much higher expenses in terms of their staff. The data will explain that. Or it may be that the earnings are widely different in the different practices, but we need to understand that, and that's what we're seeking to do.
Thank you very much. Anne Mullen.
And, you know, we would support in the deep end, because we've talked this quite a bit, we didn't really see the contract. The contract is just a way to pay GPs. It doesn't, from our point of view, address issues around the inverse care law and the inequality divide, which is getting wider again. And I think we would support the argument about what is a reasonable income for a GP, a sort of national conversation in the profession, because the profession itself is really quite divided. We don't know what rural GPs do, they don't really know what we do. You know, we're not all that joined up as a profession and thinking about income as well, and I think that's really important. And the SHIP project really put the contract aside and income aside. There was a very strong financial governance to SHIP, because none of the money that was given to the project went into the GPs as profits. It was into the staff, into the development of the project, and that is really quite key, I think, for clusters as well, when they start to move forward and mature as organisations.
Thank you very much. I think that's a very important area. There may be one or two colleagues will want to come back on that before we're done, but I'm conscious of time, and I'd like Brian Whittle to explore the issues of IT that have been raised with us.
Thank you, Gabina. I think that, David Hogg, you raised IT almost immediately, which I was pleased to see. I should probably have said right at the start, Gabina, that before I came into this place, I was actually director of a communication and collaboration platform specifically for healthcare. So it's an area of particular interest to me. And I think that what we're asking our GPs to do here in terms of that give them that time and that time efficiency, and we're asking them to multidisciplinary working in hubs and in GP clusters. We're asking them to the interface between primary care and secondary care through talking to AHPs and the third sector. My overwhelming feeling from what the evidence I'm getting is that is being inhibited by a lack of effective IT solutions and data gathering and evaluation. I don't know whether that's something you want to comment on.
IT, I think a couple of witnesses already mentioned the way in which that inhibits effective partnership working. Who would like to? Andrew Buist.
I agree. It needs to be better. We try and keep our frail elderly at home in the community and avoid admitting them to the hospital, and that often means doing home visiting, we rely on our computers when we're in our own surgeries, but when we're on a home visit, we don't have access to that. We can't see when they last had a blood test, or we can't read the hospital letter that arrived the previous week. The technology exists that we could have access to that information on home visiting, and often that makes a huge difference as to what you decide to do. It's an issue in the out-of-hours period too, where sometimes the out-of-hours doctors are working without access to the full patient record. So we need to do something about this.
Carrie Lynn.
I think it was 2015, I'm not entirely sure, but there was a big survey of clinicians across the Scottish NHS about their priorities for IT. And perhaps unsurprisingly, top of the list came make basic IT work well. And bottom of the list came the high-tech stuff that hits the headlines around remote technology and telemedicine. So that's great, but unless we've got basic IT that works really well and it's efficient and it's reliable and it's safe, then none of the other stuff can follow. You're absolutely right. It's crucial to safe interfaces of care, to being able to share clinical data between the community setting and the acute setting. Often that's missing. Patients expect us to be able to see what's happened to them in hospital, and they expect consultants and teams looking after them in hospital to be able to see what's happening when they're out in the community, and that doesn't happen. So they're always surprised about that. And in addition to that, it also inhibits, I think, the amount of anticipatory care planning that we can do in a sort of realistic way. So I have a big interest in this, having done this for 5 years as a clinical lead. So GPs can, and other members of the primary care team can create care plans for patients who've got complex health and social care needs using a piece of IT called the Key Information Summary, which can then be shared across interfaces, but it doesn't work well. So you can see it well in the out-of-hours setting. You can't always see it in the hospital setting. You can't see it in the community pharmacy setting. Can't see it in the care home setting. You can't see it in the social care setting. So all these very difficult conversations that have been recorded about patients' beliefs, patients' desires, patients' wishes about how far they want treatment to go is not being seen at the time that it needs to be seen. It can't be seen by ambulance services on the way to an emergency. So there are significant issues about being able to communicate patient wishes about what they want to happen that are not happening at the moment. Now, I know there is work being done within NES around the shared digital platform to link up health and social care and make it much more collaborative. I'm not sure what the timescales are for that, but I think we would all say it can't come soon enough so that it's working better.
Thank you very much. David Hogg and then Anne Mullen.
Yeah, I think, IT is, could be, I get quite excited actually thinking about the possibilities, not least because we're coming from not a particularly great situation. We're still, some of us are using systems from 2005, 2010, we're just not keeping up to date. And then you log into, and I won't say the names of big kind of internet companies here, but we all know which search engines we use and things like that. So I do get excited because you look at how much data we do gather in the health service and how that could be used. I would like to be able to draw easily a chart of someone's kidney function for the last 6 months. And even that's quite challenging with some of the systems we have. There's ways to do it, quite clunky, going through menus. Why can't we have a system? And I'm really hoping our new GPIT system may well even deliver this, but I don't know. But you can log into a patient and you have a dashboard that tells you more about what that patient is doing. We have it to some extent, but it's all very clunky. But importantly, we're talking about working well in teams and bringing multidisciplinary teams together. On Aaron, we merged our 3 GP practices in 2012. I'm a bit of a nerd or a geek at times, and I have an interest in IT. And we set up an intranet platform, which actually proved to be an essential part of bringing 3 previously separate GP teams together. We called it Wilma, because our shared drive was called Fred, and we went for a Flintstones theme, so Fred and Wilma. We called it Wilma, and it allowed that it meant that things like, what's the number to phone the ambulance service? What's the number to phone the pharmacy? How do you refer to a particular service? Useful for locums or new colleagues. Sharing audits. IT is such an important platform, and we're just working so much in the dark ages that it almost gets a joke that sometimes in some out-of-hours sessions I do, or some practices, it's a really nice feeling when the printer, when the prescription comes through the printer, because it feels like a mini success. We need to move on from that. And one of the hopes for the future is Estonia has led the way in terms of patient-held records and in terms of integrating that. And I think that now really has to be a time when there's lots of exciting work happening as a result of the contract, to look at countries like Estonia and see what they're doing right, because there's loads of good stuff that, frankly, if we're able to support this, and if it's clinician supported and not just coming from IT designers, we could really do something amazing with this.
Very much. Anne Mullen.
We get round in the SHIP project with our MDT meetings. The social care worker would bring their own laptop. We would bring our laptop, so our data would be on our laptop, their data would be on our laptop. And it meant that we could share information, because a lot of the time, I think the human interface has to be given parity with the IT interface, and quite often we get very excited about IT developments, and particularly in deep end communities, some IT developments are going to widen the health inequality gap if there's not an equity statement built into that. But nonetheless, at the MDT meetings, that was invaluable because we knew then who their named social worker was. They could update our records. We could share information, and that's absolutely vital. If the systems remain separate, particularly in health and social care, with no interface, whether it's human or IT, then you're not going to get that joined-up working that you really need for this complex care planning. I think the key information summary is a really important tool, but it takes time to fill that in. Only GPs can fill that in. It's a complex document. I don't see why, now that we've got addiction workers that write on case records, that district nurses couldn't fill that in when they've got the time. Health visitors, there's a whole range of people who could input into that document and upload it, but the percentage of patients that have it is nowhere near as high as it should be.
Thank you very much. Amjad Khan.
Just to echo what people have said, IT is very important. Our younger doctors who are coming out are IT literate, are using their phones for all their normal business. If you just look at banking facilities, our younger patients are also IT literate. So I think we need an effective IT system, otherwise we're going to be not serving some of our patients well.
One of our other witnesses, I think it was Carrie Lunan, said that NES is doing work on this. Can you offer the committee a timeline for the work on joining up these IT systems?
I don't have a timeline, but I can get that information.
Could you do that? That would be much appreciated. Brian Whittle.
Much as I'm just getting warmed up, convener, on this subject, I realise time is short. So if I can just ask one very short question that I think is actually central to this whole issue is around who should own patient data.
It's the patient's data, but we're just in the process of agreeing a national data sharing agreement that will see that the GPs and the health boards are the joint data controllers. So we've just about completed with legal input the template that will go out to each health board, and then each health board will have to make that agreement with each practice. But it allows then the health board to share that information that comes from the GP, which is so important for good quality patient care, but also needs the protections and meets the legislation, GDPR, that protects patients from information going to places that it shouldn't do. So it is the patient's data, but GPs and the board are the joint data controllers.
David Hall.
Very briefly, but I think that sometimes the fear of that question is retrospective. To what extent can the data that's been recorded about patients be shared? And that's a really important question. But I think prospectively, a lot of my time just now, as it has been for the particularly number of years, is managing anxiety about waiting times. A number of patients who will come in and say, I'm really worried, can you tell me where I am in the queue? And it's almost needs like one of these kind of large shops that, again, I won't give the name of, but you can take your ticket and you see yourself moving through the queue system. We're asking patients to take more responsibility for their health, to engage more with self-management and self-care. And I don't think we're doing patients as much, or not giving them the adequate tools to do that. That if I said to one of you here, right, okay, so I think we should refer you to orthopaedics, I've got no idea really how long that's going to take. And over that time, until you're seen by an orthopaedic consultant, or whichever specialty that is, that anxiety builds up. Patients carry anxiety with them, and one of the most effective ways of making patients feel included and reassured is by giving them access to information of when things will happen. So one simple thing is, there's maybe access to patient records, to blood results, prescriptions we already have with online ordering. But why can't we have a system which improves the primary secondary care interface, where if you want to know where you are in that queue and you can find out and do something about that if necessary, then access that information. At the moment, it's too nebulous. There's a trust involved and I will refer you, and then you don't really know what's going to happen after that point. So I think we have to be better about prospective information as well as what we're recording about patients as well. Does that make sense?
Okay. Yes. Thank you very much. Move on to training and workforce issues. David Stewart.
Thank you, Convener. Good afternoon, panel. Can I move on to GP training? And one of the excellent initiatives that I've come across is the ScotGem programme, designed, as you know, to interest doctors in a career as GPs. Could you provide your assessment of that programme to the committee?
Amjad Khan.
ScotGem began last year with 55 training positions, where a 4-year training program, which was linked primarily to training in the community, and was also offering bursaries as long as students agreed to work in Scotland for each year that they took the bursary. So it's a welcome addition to GP training for doctors, and specifically with the aim of increasing the percentage of those doctors who work in primary care. So it's a welcome addition.
Would any other panel members like to contribute?
Just briefly, I don't have a formal assessment of it. I think Amjad would be best placed for that, but we welcome any initiative that grows the GP workforce and that encourages medical students to choose a career in general practice. And ScotGem also has a focus on remote and rural communities as well, which is welcome. I think one wider thing to mention is that there obviously are significant teaching commitments with ScotGem out in the community, and we know that there is a capacity issue within general practice at the moment to be able to offer the level of teaching that we would ideally like to be able to offer to influence future career choice. Now, the work that John Gillis was chairing around increasing the capacity of undergraduate training to happen out in general practice, which is currently about 9% of the medical curriculum, which means that 91% of the curriculum is based not in general practice, means that you know, in reality, students have very little exposure to general practice, so they're less likely to choose it. We would like to see that increase to 25%, and we're very supportive of the Scottish Government target of that. But we recognise that that also has quite a lot of challenges around it in terms of the premises to house students and the resources required to free clinicians up to do the teaching. So I guess just a general plea, because we know that ScotGem has managed to successfully recruit trainers out in the community, but there possibly are unintended consequences of how that impacts on teaching more generally across Scotland, because we need to build it for the whole of the undergraduate curriculum.
Good.
Thank you.
Amjad Khan.
Just to pick up on Carrie's capacity issue, there is a capacity issue, obviously, throughout Scotland. We've got an educational capacity group set up at NES, which is multidisciplinary and led by my colleague Moya, who's sitting at the back. We have pharmacists, paramedics, and other allied health professionals looking at to see how we can combine training, or how we can do training together out in the community. And we're hoping to pilot some of the new initiatives later in the year.
And on a, so you can be on a related point, you may or may not be aware that the programme for government, which was announced recently by the First Minister, had a commitment for a new medical school in Scotland. Does this give us an opportunity to have young people, indeed people of all ages, from a disadvantaged background, to go in to become GPs and indeed consultants in various other aspects of that role?
Amjad Khan.
There's no doubt research has shown that people tend to, once they've qualified, tend to go and practice in the area that they've come from. So anything that which promotes training from those areas is a good thing. So we'd have to have thought into where these new medical schools would be going to ensure that those areas which are deficient in doctors are able to benefit from that.
And just in the back, just if I can follow up before I forget it, you'll know that one of the issues about retention is that we tend to be able to retain doctors in areas which have medical schools already. So the obvious, I suppose, simplistic point for me is, can we look at areas that perhaps don't currently have a medical school across Scotland? And I'm sure there'll be a number of us around this room who put a bid in a very early stage in that pact.
Yes, there are areas. People tend to go and work in a location, obviously where they've come from, but also where there are other opportunities for themselves and for their spouses and for their family. So it's a complex area, but there's no doubt that if there is an opportunity in the area they come from, and I think in England they're already putting medical schools in some of these hard to fill areas as far as recruitment is concerned.
Alan, you wanted to come in?
I mean, obviously, the DPN is very interested in this issue, and my colleague David Blaine has written a paper about, or several papers actually, about the challenges to undergraduate and postgraduate teaching in general practice and trying to educate GPs in training and at medical school about the challenges and the positives of working in DPN practices and raising that standard. But there are issues about capacity and the number of trainees that go into DPN practices, which is an issue. And I think that, again, it comes back to, about knowing what each other's role is. So students, medical students, should probably know what a rural GP is like and a DPN practice as well. So there's a bit of joined up teaching at that level as well. And also, I think, it's, hospital specialists, some may have been in general practice and understand what general practice is, but all GPs will have worked and trained in hospitals, and we don't have that balance, I think, correct.
Okay, thank you very much. I have David Hogg and Carrie Luna.
Thank you again. So yeah, and again, I think that rural practice on the international stage can offer great examples of where we might want to take things in Scotland, particularly again looking at the kind of team-based model. If it's of any interest to the committee, there's two specific examples. Roger Strass's work in Northern Ontario, developing a medical school that focuses on community needs, community assets and multidisciplinary team learning. And along with that, Ian Cooper has written about the model in Stellenbosch in South Africa, where from the outset, you mix pharmacists and nursing teams with medical students. And from the outset, if you get that right at the start of training, that paves the way of how we are likely to work together more effectively, not least because we have a better understanding of how each other works. My own experience on Iron, frequently I would be called out to support ambulance crews, which means that when they turn up to our community hospital and bring a patient in from A&E, you've got quite a good perspective of their own sort of competencies, how you can get them to help you, and also perhaps reasons why they've not been able to do something that we might have done pre-hospitally, or along these lines. One of my favourite phrases is knowledge without perspective is a higher form of ignorance. And the more perspective we can bring to how we're going to deliver primary healthcare in Scotland with all the different challenges that involves, then the more perspective we can bring, then the better. And coming back to that, on Iron we had over 90 applications a year for our elective scheme alone, partly because they saw some of the videos that we produced. They saw us pretty happy and feeling valued at that point in what we delivered. Comes back to my point that our GPAS is very, very keen to reiterate, retention underpins everything. If you've got happy, supported, keen, enthusiastic doctors working across Scotland, that's where the medical students are going to find that their learning is most supported and they feel more motivated. So let's not focus too much and get drawn into recruitment. It comes back to retention and other things will follow. Thank you.
Thank you. I'm a huge fan of widening access to medical school in every way that we can, because we are a diverse population and we need a diverse medical profession who have a good understanding of many of the life issues, particularly that we deal with in general practice on a daily basis. I think charities such as REACH, I know, have done a huge amount to increase access, particularly in Glasgow, and the college has supported that at a local level by working alongside those charities. So I think just wanted to say that I am massively in support of that. In terms of choosing general practice as a career, just going back to what we were talking about before, we've mentioned the importance of placements and exposure early on, adequate exposure, and the importance of being exposed to positive role models who enjoy their job so that they think that's what I want to do when I grow up. But the third thing that's really important, and this came from an RCGP survey done 2 or 3 years ago now called Destination GP, which polled a huge amount of medical students to find out what were the factors that had influenced whether or not they wanted to become a GP. And we know the first two because we've mentioned them, but the third one was, not surprisingly, whether or not they had heard negative things said about general practice as a profession. And that was largely, to be honest, in the hospital setting and from academics and from peers. And it's very sad that that happens, and it happens still. So I think that there's an awful lot of work to be done around, understanding each other's roles and remits across the profession, generating far higher levels of respect for each other. And a lot of that is about building the interfaces of care and bringing people together to understand the jobs that we do. But there are also roles for the Royal Colleges, for the BMA, there's roles for the media, there's roles for politicians and policymakers, and there's roles for NES, and there's roles for the GMC, in breaking down those barriers that make people think that becoming just a GP is a second choice to becoming a specialist, because it's not. So we have to challenge that if we want to grow our workforce in the future. So I think any medical school that is being established in 2019 or moving forward has to have that in mind.
Okay, thank you very much. Thank you. Emma Harper, briefly.
Just a wee brief supplementary. We were talking about like growing our own workforce, but it seems like we're all competing for the same wains. And if you're healthcare inclined, you might be a physio, or you might be a nurse, or you might be whatever you choose. But how important is it to recruit and then retain from the EU? You know, we are seeing that our birth rate's falling, so it's really important that we welcome other people to come from other countries as well, including the EU.
Anyone very briefly on that one? Anne Mullen.
I think that's a crucial point. I mean, my partner in practice is from Romania. He's a very valued GP, and he's chosen to live and work in Scotland. And I think, you know, without him being there, I think we would have possibly taken much longer to recruit someone, because he'd been trained actually in Govan as well. And you find that you know, training people in deep end practice, if they're given the support that they need, and they can see that it's a possible career choice, then they will stay, and they will go into partnerships elsewhere in other deep end communities.
It is important from EU, but I think EU isn't the only place. We have lots of graduates from countries throughout the world, and they've played a huge and important part in the development and success of the health service, and we mustn't forget those. We also have special arrangements for doctors from places like Canada and New Zealand and Australia, and just developing one for South Africa as well, to make sure, and the Republic of Ireland, to make sure that GPs are able to come to Scotland and work here, and we don't put obstacles in their way. So I think internationally getting people from all over the world is an important part of any health system, and I think especially so for our UK one.
Thank you very much. Alec Cole-Hamilton.
Thank you, Convener. I'd like to ask about recruitment as well. And as we know, the Scottish Government have set a target of recruiting 800 new GPs by 2027. Are panellists aware of why we settled on that target, how that was arrived at as being the need? And secondly, how likely do you think we are to achieve that?
Two big questions. I'm looking for a volunteer to answer these questions. Carrie Loonan.
Yeah, thank you. I'm not entirely clear how the figure came around, and I think probably the Audit Scotland report has suggested that we're still not entirely sure what the modelling is around the future GP workforce need. But our concern has always been that, you know, although it's very welcome to see a commitment to 800 additional GPs, this is a headcount figure. Yeah. And so we need to understand that that headcount figure creates massive variation in what that can actually look like, particularly with the diversity of GP working patterns. So an 800 headcount figure could be, at the worst case scenario, 800 GPs doing maybe half a day a week, or 800 GPs doing 5 full days a week. So in terms of having reliable workforce planning, we need to really be thinking about it in terms of whole-time equivalent planning, which is how most workforces planning is done throughout the rest of the UK, and indeed for other medical specialties. So I think it's really important for general practice that we understand what that is going to look like and what that means, because based on current workforce patterns, that's likely to be about 460 whole-time equivalent GPs, which starts to create a different picture.
Can I just stop you there,
yeah.
Carrie? Sorry to interrupt.
Of course.
Are you concerned that by the Scottish Government adopting a headcount target, that is actually a rather cynical move on their part, so they can point to it and say we've got 800 new doctors, everyone, whereas actually what we really need to drill down here and say, well, how many FT equivalent doctors do we actually have?
I think we just feel that full-time equivalent workforce planning is more reliable, and it allows us to know what the future workforce is going to look like, because without that certainty, we can't know what 800 additional GPs will look like. And we know that the whole-time equivalent workforce in Scotland is declining in general practice. So the headcount workforce has gone up slightly, but the whole-time equivalent workforce has gone down. And certainly between, I think it was 2013 and 15, the GP whole-time equivalent workforce fell and the secondary care workforce rose. The consultant workforce went up by 15% as opposed to the GP workforce declining by 4% in terms of whole-time equivalent. So we need to think about what do we want our future healthcare service to look like? How do we deliver the national clinical strategy where we care for more people at home or in a homely setting if we don't mirror that with workforce that looks to build community-based professionals? How likely is it? It's difficult to know because there are so many factors that will rely on, and it's around, you know, getting more people into medical schools who want to be GPs, then having more exposure during foundation year training, then choosing general practice as a career, and then staying in general practice. Crucially, we've mentioned retention is actually the biggest part of recruitment, if you see what I mean, even though it's a separate process. But it's like transfusing someone while they continue to hemorrhage. Unless you stop the bleeding, it's not going to get better. So we need to think about why it is that people leave. And I don't think we have a full understanding of why people choose to leave general practice, because it's different at different points of the career. So in the first few years after qualifying, the challenges are different and the doubts are different than they are in the middle part of your career, and that they are at the end of your career when there are different reasons why people may be choosing to step down. So I think without knowing in more detail what they are, we can't present solutions.
Amjad Khan, please.
Thanks.
I can't give you an answer for the 800, but I think in some ways the number is not important, but it's having the right number which is fulfills what we need from the health service. So recruitment is going to be a multi-pronged approach, and it's never going to be done in a day or a year. That's about increasing medical school numbers, which has happened. It's about increasing the attractiveness of GP, having more foundation doctors, experienced GP, to ensure that they are then more likely to use general practice as a career, and also increasing the GP placements that we've got. So GP 100 a few years ago increased the number of GP trainees within the system. The retention, Carrie's also mentioned, is very important, and there's a few schemes which help that. The GP returner scheme to attract GPs back again who have left GP, the GP retainer scheme, and the staying in practice new scheme which is there, and also the enhanced induction scheme. But it's important to also consider that many of our doctors who are qualifying now don't want to work full-time, they want to work less than full-time, so we need to make the job attractive and make sure that their work-life balance questions are answered.
Thank you, Convener. Many of us around the table have had very strong representations about the pensions issue, which is actually disincentivising working later into a career. Can I also ask, another group of doctors who've come to see me are the recently retired doctors, and a number of them have intimated that they would welcome the opportunity to go back into practice, maybe 2 or 3 sessions a week, just to keep their hand in, even though they've perhaps been retired just for a couple of years. But it is they face impediments to that. Should we make it easier for those doctors to come back on stream?
Amjad Khan.
There is a system for them to be able to come. I think the 2-year mark is normally taken as somebody that who's been out of practice for more than 2 years does require some sort of an induction back in. And we work with the health board because they need to be on the performers list in order to be able to practice as a GP. And then the GP returner scheme allows us to try and provide them with the appropriate experience that they need. So we try and help them as much as possible and not to put obstacles in the way. So I agree with you there that I think we need to make it as easy as possible.
Now let's go back to the wider question that Alec Hampton asked in the first instance. Andrew Bruce.
I don't know where the 800 came from. I suspect somewhere in St Andrew's House, but as Amjad said, the number doesn't really matter. What is clear is we need more GPs, particularly more GP partners, because the Scottish population is clearly ageing, and as we get older we all develop long-term conditions, and patients in that category end up in hospital with such great ease, and then they block beds in accident emergency, and they get stuck in a medical ward with delayed discharges. So it's absolutely crucial that we, wherever possible, and it's in the patient's best interest too, most of the time, that we care for them in the community. But the other important thing that we need to do is develop a mechanism for introducing additional doctors into the country, because at the moment we don't have that. But with the proposals under phase 2 of the new contract, we will have a new mechanism that will allow us to introduce additional GPs. I mean, at the moment, if you want to introduce an extra orthopaedic surgeon into your department, you just employ them. Practices can't do that. We don't have a mechanism to do that. We don't have a mechanism if the population of Dunfermline is suddenly expanding and they actually need a new practice. We don't have a mechanism to create a new practice, but the new contract in phase 2 will deliver a mechanism to do that. So we need to be able to better monitor our workload and introduce new workforce with more additional GP time where the patient needs are clearly required.
David Hawke.
Thank you. Yes, again, looking to our international confrères, there's a very important concept of the pipeline model of recruitment and retention. So you look at who's coming in and where the leaks are, or where people perhaps choose to move from their careers for more positive reasons. But yeah, if we're going to invest in 800 new doctors, there's a cost to that in itself. We need to make sure and work out, well, what's going to happen to these 800 new doctors as they move through the system? And I come back to the point both about retention, but I think we've covered that quite a lot already, because it is such an important kind of part. But the contract has, again, devalued the work of rural GPs. Rural GPs are feeling devalued just now. Now, we touched upon the EU side of things, and I know I've got colleagues who originate from the EU and not just feeling destabilised and vulnerable from the contract side of things, they're also obviously feeling very vulnerable, including their families, because of what's happening with the EU negotiations just now. And that's another part, that they are going to potentially be leaks out of the pipe, valued, extremely experienced colleagues who are delivering excellent care just now. So I think the pipeline model has to be has to be considered. But the best way of keeping the water in the pipe is, and the analogy might not quite work this way, but basically the more that we have supported, valued doctors and clinicians in the system and valued teams, that is what's going to result in better recruitment overall. So let's not lose sight of that, despite all the kind of the headlines.
Thank you very much. Finally, Sandra White.
Thank you very much, Convener, and thank you and good afternoon, I think it is, panel in that respect. I hope you forgive me, I'll go back to what basically we're actually originally talking about, and that's about primary care inquiry. And my understanding is that it's about how you, as professionals, obviously GPs, can help deliver the aspirations for primary care that we as members heard from the community about working together. And I must say, I haven't heard an awful lot about it yet, but perhaps that's the questions that you've been asked. I asked the first panel, I think some of you may have been sitting there, about educational awareness, culture change, that type of thing. So the questions that I do want to put to you is the fact that in written evidence we received comments that there needs to be a clear and comprehensive public information campaign about how to access health services and what to expect within each setting from each healthcare professional and obviously the public as well. And I haven't heard any answers in regards to how you are going to work. I mean, I've heard about clusters, about hubs, which seems to me from the evidence I've heard is that it doesn't mention community pharmacies, optometrists, it does mention physiotherapists, but from the evidence we heard earlier, the physiotherapists are being taken from the community settings and used in hospitals and also in clusters or doctors' surgeries. So I just want to ask you how you feel you're going to go about doing that as GPs without people having to go through a GP as a gatekeeper, basically having to wait for an appointment. GPs don't work 9 to 10 or whatever it might be, 9 to 8. So how do you envisage yourselves working with local community services, because I'm not one for top heavy down. It's about the community up, as far as I'm concerned, and lots of people too. And these community services are in the community. They're in my high street. People can access them when they're shopping in shopping centres. So how do you think you're going to manage yourselves working with all these other community services? And I think, Andrew, you mentioned flu vaccines. Pharmacies would be more than happy to give vaccinations, and therefore freeing up the time of yourselves and being able to go out into the community, or the community's got it on their doorstep. Sorry about all that, but I just really want you to know how you're going to do that.
Ourselves in the BMA and the Royal College of GPs have been in discussion with the government. We are very enthusiastic about the need for a national conversation. I'm sure Carrie will say more about that after me, but the primary health care is changing, and we need to bring the patients along with us. If it's just practice level discussions, it takes a lot of time and patients get confused by what's happening. We need a national conversation to explain that you don't always need to see the GP first. It's okay to see a nurse or a physio or a pharmacist, and that sometimes the receptionist in the practice will act as a navigator to signpost you to where you need to be.
Interrupt you, but I suppose you mentioned national conversation. Of course, that's what the BMA has said. They want a national conversation. But when I asked from the allied professionals this morning, and I mentioned leaflets or posters, TV advert, would you not think that would be a better way, because it's the public we're trying to reach, change their culture, but it seems we're having to change the professionals' culture as well. How long is it going to take, a conversation with no action?
Well, speaking for the GPs, I think we're up for that, and I think a national conversation starts the process, and then we carry those conversations on at a local level. On flu vaccination, just to quickly pick up on that, I'm very keen that community pharmacy picks up on not just flu vaccinations, travel vaccinations in particular. I think there's enormous potential there. We've got community pharmacies spread out throughout the country, very accessible for patients, and a good model we could go down, because we're seeking to move immunisations out of general practice so we can concentrate on what GPs do best, which is looking after patients who are unwell.
Carrie Luna.
I couldn't agree more, Sandra, and thank you for asking that question. So I think that what has been happening in practice over the last 2 or 3 years is that practices at varying levels of speed have been changing the way that they deliver care. And so some practices have been more fortunate to have members of the MDT come and join them, and some practices haven't had that opportunity. Some practices have chosen to change the receptionist role very significantly to one of a care coordinator role. But what hasn't happened alongside that is a national engagement campaign about why the changes are happening and what they mean. So what we've been hearing from GPs across the country is that they often experience quite high levels of confusion or distress or frustration from patients phoning practices and having their calls answered by somebody that they traditionally would have experienced as just a receptionist, asking them questions that maybe appear sensitive and they're worried about confidentiality, to try and get them linked in with the right person in the right place at the right time. And they really struggle with that because it's very different for many people compared to how they used to access GP services. So what is happening is that practices are having to do that education at a very local level, and it's being done in very different ways across the country. So some practices will have information screens in their waiting room, some will have done leaflets, some will have spoken to their community pharmacists, some will have it on their website, some will have messages on the phone that explain it, some have changed the names of the receptionists that answer the calls to care coordinators and have changed their badges and their training and their job descriptions. But at the end of the day, unless you let people who know who are using the service why this is happening and what's happening, then it's very difficult for practices to take that on at a local level. And we did a survey last year within the college just to find out how this was going, how the changes were going at the front line. And what we found was that the vast majority of practices had receptionists or care coordinators that were reporting high levels, like the majority of calls coming through when they were trying to have these care coordinator conversations about signposting to other colleagues within the team that patients were getting upset, or they were getting annoyed, or they felt it was rationing, or they didn't understand why it was happening. So they were finding their job very emotionally difficult because they were just trying to do what we were training them to do and asking them to do. And then also when patients were coming in to see us in our 10-minute appointments, we were spending maybe half of it explaining why that had happened and that that wasn't a bad thing, that that's what we'd asked our receptionists to do, and that it's not about, you know, seeing a replacement GP, it's about seeing someone who's possibly more qualified to see you with that problem.
So basically, is that why there should be a national campaign?
Yes. So it needs to, yes.
Takes it out of the doctor's hands.
Yeah, it needs
frees
to be
their
both.
time up.
Yeah.
So it's got to be a national campaign.
Yeah. And there has been commitment to that now.
The public, before they get to the doctors.
Absolutely.
What is available
so
for them?
There has been commitment from the Cabinet Secretary to a national campaign, with leadership being offered by Scottish Government to look at what that campaign will look like, working with healthcare professionals and patients to look at what does the messaging look like, what seems to work well, what doesn't work so well. And that work has really just started in the last 2 or 3 months. But I'm hopeful that that will make a big difference to help people to be able to make best use of the service and feel that, you know, many of the changes that are happening have good reason behind them, and so that they don't experience the distress, the frustration when they phone.
Thank you.
And finally, although I see a late bid, but I was calling Anne Mullen.
Well, just briefly, we've got now big posters in our waiting room about you can go and see a pharmacist for this upfront, but it takes time to educate patients when they've seen the GP as the sort of person that they go to for everything. And even with having the physio, we have an attached physio that's come through this project for 3 years. That's still a difficult concept to get to people that they self-refer. But a lot of patients are aware that they can self-refer, and we really shouldn't see sore eyes anymore. They should go straight to the high street optician. But that still takes some time to embed. So even it's about the national conversation should really be a rolling conversation. It shouldn't just stop after one conversation, because you're talking about a complex system that also changes. We find the complex system quite difficult to navigate at times. So patients who don't have access to hospital numbers, etc., will also find it difficult. And then for deep end communities, health literacy can be a big issue. So you have to then consider the changes that you're doing have to be able to affect everybody. The links worker obviously is a very important point of contact for us, but they're embedded in the practice, which is really, really important.
Thank you.
David Hogg, very briefly.
Very briefly, yes. So I think there's interesting things happening. There's the Quick system, for example. One of the practices I'm working in is about to roll out CWIC. So patients are signposted from the outset. And as Anna, I totally agree with you with that. And it's a really complex system for us as clinicians. And you think exposing that complexity to patients, no wonder we're struggling to get that level of self-care. My answer to your question is responsiveness. And there's something tricky about when I say to a patient, you can self-refer to physio, and I know the physios are fantastic colleagues, they've got so much to offer, and I think sometimes we undersell, or sometimes they perhaps themselves undersell what they can actually do. But when you phone up a phone line, you're then told, right, that's fine. Sometimes the phone lines have a feeling that they're trying to not let you see someone, and on top of that, you're then told there's a waiting time of 40 weeks. We needed to be responsive, because then at the end of it, most phrases now, and again, Australia's done some work on the views of GPs, but at the end of most kind of health messages, if you're concerned, go and see your GP. There's two aspects of that. One is, let's resource the system so that it is responsive. We've got a fantastic system where we can access free of charge a GP. That's a great system to kind of focus on. But let's work out how we can help patients to understand the complex system that even we, as clinicians working in the service, struggle to understand. Thank you.
Very much, and thank you to all our witnesses today for what has been a very full evidence session. I see an even later bid for that from Andrew Buist.
Just one final brief point, which I think really has to be said, that there are tensions between rural and elderly practices and urban deprived practices, but one of the fundamental problems that this committee needs to be aware of is that there's a lack of investment in general practice. So our share of the NHS resource has dropped from 9% to under 7%. Our colleagues in Royal College of GPs have been campaigning for 11%. That is what we need to deliver the national clinical strategy. All of our problems relate to the fact that we are underinvested in general practice in Scotland.
Thank you very much. You didn't miss that last opportunity, so well done. I will say that there are a number of questions we didn't reach, in addition to other information that you may wish to offer to us. So we will be in touch with our witnesses from the earlier panel as well as from this one, and be grateful for responses to any further questions we may have for you. Thank you very much for your time. We will now briefly suspend and then resume in private session in 2 minutes' time. Thank you.